Hello, everybody. My name is Alexander Flor, and I welcome you to the 35th International Varady Workshop and the first Veins International Congress. Unfortunately, because of Corona, we had to go online, virtual, so it's the first virtual meeting. We have 580 people registered. And I want to welcome the associated societies, which is the Austrian Society of Phlebology, the Austrian Society of Surgeons, and the Professional Association of Austrian Surgeons, and the FIVIN Association. Welcome, everybody. And I want, beside the speakers, welcome our panelists, Sergio Giannesini from Italy, Philip Herzmann from the United States, Lowell Kabnik from New York, Jaroslav Kalemba from Poland, Mark Whiteley from Great Britain, Shoaib Badaria from India, Malay Patel from India, Larissa Shanuka from Ukraine, Imre Bihari from Hungary, Se Gonzalez from Chile, and Horst Peter Steffen from Germany. Welcome, everybody, and thank you very much for your support. I personally met Professor Varady in 1999. I was operating in Innsbruck, and they had an instrument there, and I asked my colleague, what's this instrument? What's the name of it? At that time, we used to make big incisions for phlebectomy, and they told me it's the Varady hook, and I said, what is Varady? And they said, Varady is a surgeon in Germany. So I looked for his telephone number, I called him, and he was fantastic on the telephone. And Professor Varady told me, come to Frankfurt to my clinic. And so I came there, and we became good friends. And it's a big honor for me now, today, 21st of November, to make this virtual meeting. Thank you very much, Sultan, for all your help you gave me in the last 20 years. And please say you're welcome for the Congress.
Dear colleagues, unfortunately, because of Corona, we could not hold the 35th workshop. Thank colleague Flor and other participants, the workshop could take place virtually. I wish you a good meeting. Thank you very much.
Thank you very much, Sultan. And Khaled, we go on with the first presentation, which was recorded from Professor Varady, the mini phlebectomy according to Varady, the technique. Please go on. Khaled?
The history of the 35th workshop.
No, not the history, the technique, Khaled. The technique.
So other countries and cities can be integrated. The workshop had many participants before I founded the Society International Forum for Mini-Surgery of Varicose Vein.
Wir haben zwei parallel laufende Vorträge. Alex.
Khaled, we have two presentations running.
You see, the phlebectomy as
This one, doctor, is correct one?
concept of
Correct, yes.
varicose veins according to Varady. The phlebectomy is very simplex. We have the hunch in the spatula and broaden it very fast all over the world with great success. You can often ask yourself if the great effort is really necessary for the medical need and success. The majority of patients suffering from varicose vein are women, and for and therefore is not only the medical but also the cosmetic aspect also considered. You see, the greater the effort und lower the effort. Many had tried removing varicose vein through micro-incision, using more or less appropriate instruments, a small hook, you use the doctors without considering that the vein are fixed. Also you can pull the vein not without spatula. The vein is not earthworms. You cannot pull. You see here very much small incision and therefore is bad result. More than 30 years ago, I developed a method. The company Escola provides the necessary instrumentation. The Varady hook is a traumatic hook. It is the first method based on surgical principles together with matching surgical instruments, the flap extractor and the flebodissector. Is the flap extractor. You see, one side had a spatula, andere the hook, other side the spatula. Und the flebodissector, this had two spatula because the spatula very important. I show again. Only the professor then had the idea, necessary the spatula, only the instrument was no longer here, and therefore I present mein Instrument und he took mein Instrument. Also Professor Dietmar von Mato Grosso took mein Instrument. We use local anesthesia, infiltration 0.25 solution because necessary much solution, not dangerous. Prepare the varices. You see here the skin lift is visible. Preserve of liquid to pressure of the liquid to preserve the bleeding. You see here this we have and really no bleeding, but only capillary bleeding, and that's enough. You see, we used very small scalpel and the bigger scalpel, 11 for example, for me inapplicable. You see, through the very small incision we pull relative big veins, and therefore not only the medical, also the cosmetic aspect also necessary. Here you see the small effort and the best results. With the spatula after the incision, we prepare all direction, and after turn around the instrument and the vein with a hook, so you see here better, between a hook and the fingertip you have the vein. 20 years I have been operated over more 10,000 patients, and we don't make crossectomy and stripping. The Safena have all patients, and all patients have excellent results. You see, an operation I can present this local anesthesia. You see here very, very good the local anesthesia between the tissue and here. The local anesthesia continues, and after we make the very small incision, before, okay, you see, incision and after, with the spatula, we prepare the vein all direction, and that's very necessary, and you see, we don't have bleeding. The local anesthesia, the pressure is very good for the bleeding, and we don't have bleeding. After we take the hook, you see, and look for the vein. Now we have the vein and a very small spatula. Prepare again, and the mini mosquito will tip the vein. You see the vein now very good, and prepare again all direction. Also you see, we use the spatula more than the hook. The hook is also very necessary, but the spatula used often. And we take the under mosquito, you see, and prepare the vein. You see, not bleeding, but prepare necessary often. Also the operation is and really prepare, and prepare. You see here the vein, and with a mini mosquito we pull the vein. You see the vein come out. Okay, and continues about I show the postoperative advantages mini surgery compared to traditional surgery. No scarring, no imprints, no bleeding, short postoperative treatment, short hospitalization or ambulatory treatment. And compared to sclerotherapy, no pigmentation, no painful induration, no painful incision necessary because no thrombotic coagulate developed. You see, the radical treatment does not prevent recurrence, it has just risk. Also, we don't have crossectomy, stripping, narcosis, lumbar tumescence, only local. You see, before and after, this regio is not simplex, but you see, you can make very, very good the regio knees. And you see here, before and after, very good results, but I want to show the foot. You see here the vein and here also. I want to present the operating slides. For this region is the mini surgery is optimal, as you can make carefully, not painful. And you see here very, very small incision. The vein is here, and after is optimal. But this patient was a pilot and had to give up his job because of severe pain, continued tissue and tendon injuries. He had movement problems, as a very traumatic method was used to operate on him. You see here big incision, 1, 2, 3, 4, 5, because the method is very, very bad. You see my method again, you see, very good. And here also before and after. I want to said, if the patient, for example, very old, you can make 2 operations. For example, this first one and after second one between 1-2 weeks. You see, it is the head like a pencil. We take the 3 fingers and rotate the finger, between the finger. The instruments you see hexagonal, therefore had very good handling. You show again here, I don't know. So, and here the flap extractor and the flap dissector. Again, I want to present the spatula of the flap extractor. You see here is rigid for good tissue penetration, therefore is used first. The other, the flap dissector, the dissector is longer, flexible, and permits longer preparation range. We use, of course, second one. And the instruments, the flap extractor, the spatula, have optimal curving. These so-called instruments you held with a full hand, here you see, without spatula is useless. You see here, without spatula, useless. To achieve good result, it is not necessary to use complicated and expensive method and instrument, but to use your brain and the skills, your hands. Summary: mini-surgery phlebectomy, according to Varady, using hook and spatula, suitable for all forms of varicose vein, all areas of the leg, all situations, ambulatory or short stationary treatment. Advantages: only few incisions and based surgical theory. You see here the phlebology garden with crosser here. And thank you very much.
Thank you, Zoltan, for your presentation. We know you are a legend, and everybody has to know Zoltan Varady started this technique in the 60s, 70s, where everybody had big incisions, crossectomy. It was quite a bloody procedure. And at that time, it was a revolution, or let's say a flevolution. There was one question from Turkey that they also use the Varady technique and they have a lot of recurrency. So it's a very good question. We have to always think about there's the Varady hook, but there's also the concept of Varady. And the concept of Varady is to leave the saphenous trunk inside the body. And nowadays we have to take the work from Peter Luger with the asphalt technique. And it's a very similar concept, just Zoltan invented this technique in the 60s, 70s. At that time, it was quite fantastic. And I think the question is right. If you have real C3, C4, varicosity with a big trunk of the saphenous, I think we should go for the ablation. But this might be a question to the panel. Mark, do you have any comment on that?
Thank you very much. Yes, I very much enjoyed the talk, but I think it's a very select group of patients. I think even Peter Luger now, the last couple of times I've seen him talking, Paul Peter Luger has sort of said he now has his type A and type B. And a lot of his patients actually now he would not claim are treatable just by distal phlebectomy. If you have truncal reflux all the way from the groin, you can do you can decompress the system a little bit, taking away the varices, but you don't get to the underlying pathology. And I'd say, therefore, I think this is a superb technique to use by itself in some patients, but as a combination technique in most patients. But I do think nowadays with venous duplex ultrasound, we have to be careful not to say, not to try and say we don't need to be thinking about underlying reflux.
Okay, thank you very much, Mark. The title of the workshop from the Congress is always the combination of endolaser and phlebectomy. And so we will go on with Dr. Maurins, and he will present his work. He's an old friend of mine, colleague. He runs a big vein clinic in Riga, Latvia. And please, Uldis, come on with your presentation, which will be fantastic, like always. We have been together to Mexico. We had a lot of traveling together. Welcome.
Yeah. Thank you. Thank you for Alexander for inviting me to this meeting. I would like to present my presentation about endolaser and mini phlebectomy and how we do it. Here you see my disclosure slide and beautiful view on Riga, and all of you, and also you, Mark, you are invited, to come to visit also me, because it is very interesting, like also here to share experience and also opinions about different topics. When we are talking about laser ablation, then of course most important is wavelength that we are using. And all of us 20 years ago, we started with 810 or 940. Then for last probably 10 years, our gold standard was 1470. But nowadays, actually in Baltics and also in our clinic, we are for laser ablation, we are using 1940 because of higher absorption, 4 times higher absorption in water comparing with 1470. What we get from this 4 times more absorption, actually, I think very important point is that we don't have any more carbonization or sticking to vein wall, also for big veins, because actually in Baltics, we are dealing also not only with small veins, but also with patients with big or very big veins. And if we are looking for this start, problem was, of course, we can treat also veins with 810 or 980/40, but problem was pain. And actually patients at start of laser ablation have pain for long period of time. And with 1470, we have resolution of this pain. And nowadays with 1940, we have actually resolution of carbonization and also possibility to treat also very safe mode or also very proximal veins. It means nowadays with 1940, we really can perform also real laser crossectomy and go very close to deep vein. A little bit about evolution of technology. Here you see this 1470 laser what we are using, and the best combination for many years was combination of 1470 in radial touring fiber. Then we get also this radial slim with 1 ring, and after that with 2 ring. And then we started to make our trials with 1940. You can see this old prototype machine. Nowadays we have this laser in very typical Leonardo device. And some years ago we get also Swift 1 ring fibers. Why I show all of this? Because of those fibers we have different diameters. It means nowadays we can really for every vein to choose for optimal vein diameter, and usually those slim or Swift fibers we're using for small veins. It means more for aesthetical indications, and radial touring fiber, it is actually universal, but usually nowadays we more use this fiber for medical indications, for big veins. And here you can see this, our standard combination of nowadays 1940 laser and pullback machine. What gives us this pullback? It gives us standardization. And of course, you see how we're performing this in my clinic. And you see that we can standardize laser ablation and treatment also between users. It means that every patient who is treated from our doctors, surgeons in our clinic get very similar results after therapy. When we speaking about treatment, I mean, more crucial is ultrasound and ultrasound investigations, because with ultrasound we get this strategy when we are performing here directly in operation theater ultrasound investigation. We are looking for proximal and distal insufficiency point. We are thinking which segments we are doing this work, how we will treat, which segments we will treat by using of laser, which segments we will treat by using of mini phlebectomies according Varady, and also with this definition of where we will start, where is proximal insufficiency point and distally insufficiency point. It is very important points, and also measurements of vein diameters and thinking about power and how many energy we need for actually treatment for every segment. Laser crossectomy, beautiful picture of saphenofemoral junction of Markus Stucker from Germany. And here is, I mean, it is crucial point, especially for treatment of great saphenose, because you see between terminal valve and pre-terminal valve, a lot of side branches is coming into saphenofemoral junction. And if we will treat this junction like it is protocol, it is usual protocol of lot of different producers, 2 centimeters below femoral vein, then of course we will be with our laser probe tip of our fiber below this preterminal valve, and all of those branches will remain untreated. Actually, in Latvia, we never treat veins also since 20 years ago from 2 centimeters. Usually we start our ablation from this saphenofemoral angle, from this distal angle. It means below epigastric vessel or at level of femoral veins. Nowadays, what changes we have nowadays? That we are trying to go very close to also this section. It means at this angle, it is more proximal angle of saphenofemoral junction with our tip of fibers. This was our very typical positioning for many years. You see this below of epigastric vessel, it is fiber position. And now we are coming very close to this portion. You can see this terminal wall. We are trying to come to this most proximal angle to perform crossectomy or laser crossectomy. What is important also for this is that we are trying to place more tumescence. You can see here more tumescence between femoral vein and great saphenous vein, and we are trying to bring in more straight position this angle to also to be able to treat those most proximal part of great saphenous vein. You can see in picture, an ultrasound picture, how we are performing changes of angle. Here you can see this result already after 10 days. You can see the shrinking of the vein from 11 to 5 millimeters, and very perfect laser crossectomy at level of femoral vein already after 10 days. Another patient before and after, you can see in this ultrasound picture, steam bubbles in vein wall directly at level of femoral vein. And this is result 3 months after therapy. You can see precise laser crossectomy in some small video, also precise laser crossectomy. Here you can see next important trial, results of our trial. It means in past, of course, like Mark tells us, we can treat trunk vein by laser and directly perform also mini phlebectomies. But in this trial that we do 10 years ago, it was very interesting that what we found out in this trial, we have performed only laser ablation of trunk veins. You can see result, shrinking of vein 1 month after, perfect laser cystectomy, but we have not to perform many phlebectomies at the same time. And what was interesting is that you see this result without performing of phlebectomies 1 month after, that in 80% of cases, we have a resolution of tributaries without any treatment. And we introduce it in our clinics in Baltics, 2-step operations with possibility to reduce traumatization and avoid what is important, avoid unnecessary phlebectomies. If we are doing only in this style, then also what's interesting in this trial, it was 7 years ago, that if we are performing only laser therapy of trunk veins, there was no differences between results with and without compression stockings. And nowadays we are treating our patients, if we are doing only laser ablation of trunk veins, we are treating them without any compression therapy after. So in a summary of laser ablation, it is very important to use this very individualized approach to every patient and every limb, every vein. And of course, it is very important point, it is strategy, how we are using, what we are treating, where, and how much energy, and where we start, where we end with our ablation. So now next, our topic is mini phlebectomy according Varady. Thank you, Professor Varady. He is my teacher in this method, and I am very thankful to Professor that I was able to learn from him. And here you can see Professor Varady, how he is teaching our doctors in Baltics in one of our master classes, how to perform mini phlebectomies with his technique. And actually nowadays in our region, all patients is treated by using Varady hooks without any scars. How it looks, you can see patient before and after with big veins, and you can see that also if we are doing this in one setting, for example, like here, laser ablation, mini phlebectomy, and after 1 month, practically no scars is visible on leg of our patients. Another one patient, more aesthetic indication. And also you see that those scars are less than 1 millimeter and practically invisible 1 month after. How we do it? Important is that we are not using any knife for performing. It is also important point for standardization. We have 3 different needles in clinic. One is performing less than 1 millimeter incision, more for aesthetics, and 2 needles with 1.2 millimeters, 1.4 millimeters standardized cuts. It means it is also a point standardization of incisions between doctors, between surgeons. It is all what we need for phlebectomies. You see needle, Varady hooks, different mosquitoes or peons and scissor. As I told already before, most important point, in my opinion, it is planning of treatment. Also for many phlebectomies, you can see how we are going very carefully through the veins by using of ultrasound. And what I'm trying to do, I'm trying to mark perforators and division of branches. It means that how precise, to be precise also during therapy in performing after that mini phlebectomies. Another one patient, also very similar, you see under ultrasound control performing the mapping of branches. Here patient mapping, before mapping, after. Another one patient for small saphenous, for accessoric vein, very similar. Then next point is tumescence anesthesia. We have little changes. Professor Varady shows us this local anesthesia. Actually, nowadays, we are not using any more local anesthesia. We are using pump, and we are using tumescence anesthesia. In my opinion, it is important because it is tumescence, but very precise tumescence around target veins or target branches. And it helps us also to, already before we starting operation, to get vein preparation, hydraulic preparation of branches. And you see it's reduced after that traumatization, and also we have less bleeding also after during treatment. Venenphlebectomy, here a little bit how we are doing this. Very important is, as Professor Varady already shows us, that we are using not only hook is important, but also spatula, and also when we would like to find those veins, also to use a finger or thumb in finding veins. And you can see that we can actually, by using of spatula, we can make very rare incisions, and if we perform very precise those venenphlebectomies, and you see preparation of veins and the use of, do you see finger? My finger is between, how to say, hook, vein, finger, it's all works together. And then we can treat also really big segments of veins with less incisions to very small incisions, and very, very atraumatic, with no bleeding. What is also important point is use of ultrasound also for venenphlebectomies. For example, here I would like to show this, that if something broken, then always by using of ultrasound, we can find very exactly this place where veins or segments, what is broken, and it helps a lot. It means nowadays we are performing also those venenphlebectomies ultrasound guided. It is also different from past. So in conclusion, we are treating also from proximal to distal varicose veins. Trunk veins, as I mentioned before, we should treat before, because in my opinion, especially if we have huge reflux in trunk veins, then of course we need to treat first, usually by using of laser ablation. And my recommendation is to do not venenphlebectomy in the same session, to discuss probably more with your patients, and to do this delayed after usually 3 months after treatment of proximal reflux. So also for treatment of branches, yeah, very individualized approach. Very important is this precise planning of treatment. This is our treatment protocol for 1940, what we are using in our clinic. And you see, for big veins, we're using Turing fiber, usually for small veins, Swift fiber, no compression, cold tumescence, 1940 laser, 8 watt power for radial Turing, and 6 watt for Swift. You're using this pullback device, calculation of energy, you see, by using this formula, anticoagulation only if necessary, painkillers in case of pain, and my recommendation is staged treatment for side branches. Here, very small picture, last picture probably, you see Alexander Floor in center, because he also was visited, also Zoltan Biom is there, and Kazu Miyake, and all our Baltic doctors. And I mean, of course, I hope that in some months, hopefully we will be able to meet each other, not virtually or in webinar, but actually a meeting where we can also discuss and show our techniques for doctors. Thank you a lot for your attention.
Thank you, Uldis, for your excellent presentation. There's one question from the audience. It's about a 1940 endolaser. Do you have a special approach if the vein is epiphyseal?
Yeah, I wanted to add, thank you also very much for all this. This was a very, very good presentation. I had never so very good place that all this had better. Yeah, thank you very much.
Uldis.
Yeah, for epiphyseal veins, do you mean straight epiphyseal veins? It is also those changes what we have actually with 1940. With 1940, nowadays we are treating also those straight segments very close to skin. And we get really good results and also fast resorption of those veins. It is also different if we compare with 1470 crossectomy and also possibility to treat very superficial vein segments.
One question to you: if you treat the epiphyseal vein with the endolaser, do you use higher energy or the same energy like intrafascial?
It depends on vein wall, because here was already one question about vein wall. If it's actually for accessoric vein, it is the same, but if it's probably more obese patient or man, and it is also differences in veins between females and men, and of course a little bit more energy. And with 1940 also actually it is good that also we can apply more energy, because important is to destroy adventitia, go through all, how to say, vein wall layers, yeah, and to destroy adventitia, because then vein is resorbing faster. It takes then actually 2 to 3 months. For big veins, probably 6 months, yeah, and it is completely till complete resorption of this vein, and with very low level of possibility of pigmentation.
Thank you very much. Now we have to know we have Lowell Kebnick with us. Hello, Lowell. And I think it's the question to you now. Inner crossectomy, laser crossectomy, some comments.
Yeah, I think it's a very interesting technique. When you use a side-firing laser fiber, it makes a lot of sense to go up to the junction and use that. So I think even early on when I was doing radio frequency, I had no idea about what I was doing. So I would go up to the junction. This was before we knew about thrombus extension, and I had no problems. Then all of a sudden we had to go back to the epigastric vein to blow that heat up toward the epigastric vein, and that was an issue. However, with a forward-firing laser, we found that if we were back 2.5 centimeters, that there was less of this thrombus propagation. With the fact that you are going now trying to ablate all of the truncal or inguinal veins, including the anterior accessory saphenous vein, which is most common in terms of recurrence, my question to Oldest would be, as we go out further, why aren't we seeing neovascularization like we did when we did surgery? So if we're including all of those veins at the junction, even if they are not refluxing, shouldn't we see neovascularization like we did when we did surgery and did primary ligation?
It's really a good question, Lowell. Of course, there is differences between front-firing laser fibers and side-firing laser fibers. And nowadays, with side-firing fibers, radial fibers in combination, especially with 1940, we have, as you saw, very precise result and a possibility to ablate vein directly from deep vein level. I know that also in Great Britain, Neem Yake, he published also their paper is about radio frequency ablation. And what is interesting, he is also doing in out of protocol, because he performing those ablation in 5 millimeters with different radio frequency devices from deep vein without any problems. It shows that he actually experts with how to say, huge experience, or a lot of performed operations are tending to go closer to deep vein and improving their results in long term. What we perform all the way it was 5 years ago, we are conducted a trial where we actually, because of your at this time at your results, we performed trial where our colleagues, Dr. Yuris Reeds from my team, randomized. We are made 2 groups of patients. One group we are treating randomly 2 centimeters below of deep vein, another one at level of deep vein, and nowadays we have 3 years results. And what is interesting is that in 2 years, in 2 centimeter group, It means we have more recurrences, more refluxes in saphenofemoral junction, and also more recurrences in accessoric vein. But those recurrences, what we usually see after crossectomy, we don't see anymore with neovascularization through those small veins. It is not typical what we see. And of course, what is important point, we can improve our results also if we are coming closer, and also if we are doing the shrinking of vein, and it improves our results in long term. Of course, if it's interesting to you also to get those results, long-term results, good.
Thank you very much. That was very informative.
Yeah. Thank you.
Okay, Uldis, thank you very much for your presentation. And first I say hello, Philip. I see you now. Hello, Philip Herzmann from. And I welcome now Petar Dragic from Serbia. He's like the king of Serbia. What you told me, you were before a cardiac surgeon, and then you switched on to phlebology, and you started very early, like 14 years ago, with the endolaser treatment. And your talk today is the endolaser and mini phlebectomy special cases. And I think you're welcome from your clinic, what I see in the background. Hello, Petar.
Yeah, hello to everybody. It's really a great honor to be here, the Varady Congress and in the International Congress in Vienna, becoming more and more important, especially because the topics that they're dealing with is very essential. I mean, I'm a cardiac surgeon in my beginning, my base is cardiac surgery, but later I crossed to the phlebology, and I find out how to this kind of precision of cardiac surgery move to the phlebology. So that's why my intentions are to be also is perfection in that surgery. Right? I would love to present you our presentation here in what we are doing here in our clinic. I would love to make also a small introduction about that phlebology is not only the illness, it's also aesthetic problem. So everything what we are doing needs to be connected also with the aesthetic. So every technique that I'm making in my clinic should be dedicated to perfection, to aesthetic, to everything what is connected with that, and phlebology is really connected with that. So this is the space of my clinic, and as you can see, it's like a laser beam is going through the vein. It's somehow the architecture connected to the things that we are doing. So mini phlebectomies and endovenous laser is both of those procedures are the crucial parts of my work, because with that kind of approachment, so I achieve the best aesthetic results, and that's why I'm using this kind of technique. Also, the high precision in the endovenous laser approach is necessary. So my experience is based in more than 15,000 procedures, and we are creating the techniques, the new techniques, which is necessary and essential for the successful results. These techniques are laser crossectomy and subfacial perforator laser ablation and ultrasound guided laser ablation. Those are the techniques that I'm using in everyday job. It's not a technique like just for the presentation. It's the standard part of my everyday job, and I cannot imagine to working with laser and not using those techniques. So laser crossectomy is, as we all already know, it's approach to the zero level, to the level where is the border, the very border of the very junction, and it's this technique is known like a level 0 approach. Is a technique that is giving us opportunity to have a less recidives and a better recovery. So this region of the saphenofemoral junction is important not only because of the several branches that we have there, but also because of the small capillarities. We have a small capillarities in the first 2 centimeters of the junction, which we cannot see really because they're too small. And after the small period of time, if you have a recurrences in saphenofemoral junction, then you will have a lot of small capillarities. We can call that like neovascularities. But in my opinion, this is not a new vessels. This is the existing vessels who were dilated like during the time because of the pressure in the deep vein. So as you can see in this picture, we have a lot of really, this is the main crossroad of the superficial vein system. And this is very important. Practically, this is like an organ of the superficial vein system. So laser cystectomy is considering, like, the first step is positioning the fiber, and due to the glass cone, the fiber tip is very visible, and you can easily make positioning of the fiber at the lower limb of the saphenofemoral mouth. The second is giving the tumescent anesthesia, as you can see here, like a sandwich principle, from above and under the vein. You have only to be careful about the artery, which is laying here in this angle. The third thing is laser ablation, which is starting just from the 0 point, and after that you can see very natural findings of occlusion. So you can see here, like, positioning, tumescent anesthesia, and the ablation. Also another example. So you can clearly see really how we approach it to the junction. I mean, from the technical point of view, it's very important to do that in the longitudinal projection, because you can see the tip of the needle, and it's very important because of the presence of the big vessels in surrounding. Here again. So I'm just going inside of the deep vein just to show how to make the positioning of the fiber and the starting of the radial emission. Here you can see very naturally occluded the vein. This is the Mickey Mouse projection, and you can see clearly, this is longitudinal projection, you can clearly anatomical shape of the deep vein, of the place where was the starting point of the ablation. So this is why we are speaking about, because if you're starting with the 2 centimeters below, after that we usually can find in some period after that, we can find a stump, which is also sometimes is also the finding after the stripping, or if we have a starting point of ablation 2 centimeters below. So here we can see one stump that we find in one patient who were treated with stripping. You can see here in longitudinal projection, you can see the stump. It is, you can see it like 2 centimeters. And this is the approach to the stump. So if we are not doing laser cystectomy, in that way we cannot do nothing with that. So only with the laser cystectomy we can treat this stump, even if it's short, like 1 or 2 centimeters. So here you can see positioning of the fiber and ablating these 2 centimeters. This is another example. The stump is only 1 or 2 centimeters. You can see direct approach with a needle, and through the needle I insert the guide wire. Inserting also the fiber inside of the deep vein, and after that pulling back to the 0 level, making the compression with a probe and starting with radial emission. So we are not only like right now, as we speaking about that, we are crossing to the 0 level, to the fascial level. We are going to the really junction. It's like a ground zone. It's not. We can go even deeper. We can go into the deep vein system, so we can treat also the perforating vein inside of the deep vein system, some kind of embryonal veins, central vein or axial vein, and we can also treat those things. So right now we are going even deeper in the level deep. We are calling it a level deep, and I will give you some examples about that. Because if you're treating the perforating veins only on the surface, we often find another perforating vein after that, like a recurrence. So we need to go even deeper in the subfascia to treat it below to the fascia, and that's how we can make successful operation and lower rate of recurrences. So these are some special cases about that. So you can see here deep vein, deep and artery. You can see here the dot vein, dot perforating vein here. This is the fascia level, so we're going below, progressing to the deep vein, and finally we also make the disconnection from this insufficient perforating vein from the superficial vein system with a laser, inserting the laser. You can use the direct approach also with a small fiber or with a slim fiber. It's very practical and very easy to handle with. This is the hunter vein. So you can see, like right now we are 3 or 4 centimeters below to the fascia level. Anesthesia. And ablation. So another ablation of the lower leg perforating vein, which was a nice school example. You can see here the cocket, one perforating vein. Also direct approach with a laser, going inside, deeper from the fascia, and firing. So another thing that I would love to introduce you also is also the daily part of our work, and I can't imagine any other way of laser ablation, because I think if we are doing with a laser and if we are practicing with a laser, then we really have to know what is happening on the place of ablation. So because from the several reasons, and the energy output of the laser is determined by vein diameter by most practitioners, meaning larger vein diameter equals more energy per centimeter, but the vein diameter doesn't always correspond directly with the intimomedial thickness. So you can see here we have the same size of the veins, but the different size of the vein wall. So you cannot treat the whole tree vein in the same way. Like if you have a diameter formula for the vein, you will use the same energy for all of those veins. But those veins, even if they have a same diameter, so they don't have the same thickness. So like Uldis told us before, I agree totally with that, that adventitia is really important to destroy. So you cannot destroy this type of the vein with the same energy like you're destroying this type here. So it means that you have to adapt the energy, and the best way to adapt the energy is to monitoring the place of the ablation. And you can monitoring the place of the ablation and the vein wall by directly view with the ultrasound, and it's very also practical that you can make adequate putting the energy in the vein wall. And we have better percent of occlusion after using this method. You can see here there is two different types of pulling back. In the left slide you can see very fast pulling back, and in the right side you can see slower pulling back speed. I put those two slides just to show you that I'm using the different speed of pulling back, because it's not that every vein is the same. Here of the left side, the vein wall is tiny, and the right side, you can see the process of ablation is much slower because of the thickness of the vein wall, and that's why I am just optimizing the energy. Also here you can see on that slide this line, what you can recognize like a line of adventitia. And if you put the probe in longitudinal direction, you can easily recognize the vein wall. And with the progressing of the ablation, you really can clearly see, are you destroyed or you not destroy the vein wall? On this right picture, you can see the ablating track. Here is the fiber, the glass cone of the fiber, and you can see here IMT, intimomedial thickness. And so by watching that, by watching the process that you are doing, you really are participating in the process of the ablation, instead of like using the blind pulling back or pulling back device. Pulling back device is a nice helping tool, but it cannot give a precision like you can give it with your eyes and with your hand. So in the daily practice, we achieve a much better occlusion rate with this kind of approach. And right now we are using it every day and in every vein. So here is also one case of when you can recognize the very thick vein wall. Here you can see like the vein wall, which is more than 2 millimeters in diameter of the vein wall. This is post-thrombotic vein wall, and you cannot treat that kind of vein wall with the same energy like with the formula of diameter. So you have to adapt the energy. And that's why the ultrasound guided laser ablation is, for me and for my daily practice, very important. Here you can see also ablation of the vein wall, which is very thick, that I show it to you in the example, this post-thrombotically changed vein wall. And here you can see the line of that adventitia. If you still not recognizing that, like I was speaking before in a few slides, here you can see it clearly. And you have to practicing that. If you want to achieve a better result, you have to practicing that on ultrasound. And finally, you will start to recognize the vein wall, and with that, you will adapt your energy. Also, it's important not only because the delivering of the energy, it's also important to make the good compression between the vein wall and the fiber tip, because only if you are above the vein with a probe, and only if you have a good presentation with the ultrasound and good longitudinal view, then you are really above the vein, and then you can make a good compression. With a good compression, you can also achieve. With a good compression, you can also achieve. The better contact. With a better contact, you will achieve not to cooking the blood inside of the vein, and you will directly transmit the energy to the vein wall. So this is the really some important thing that we are doing. And the second really important thing that we are also practicing in our clinics is mini phlebectomy. I was really surprised when I was starting with the phlebology. I was visiting Dr. Udis Maurins, and I was obsessed with that technique that I saw it for the first time. It was phlebectomy. The way that he was doing that was perfect. I took that technique and make a copy paste in my clinics, and also after that I was very glad because I met Professor Varady and Alex Floor in Varady Congress. It was like, I don't know, 7-8 years ago. And from that time, I started to use this technique, and of course, develop my own way of making the phlebectomies. And I would love to show you some of that presentation. I'm sorry because of maybe the movie will not be with too much light, but we just made it yesterday because we were in a hurry. I was traveling these days, even of Corona presence. But here is the patient with a really not so nice vein and not so nice look. Here is one big perforated vein. This is the way how we mark the leg, and this is our technique of doing that. The point of phlebectomy is really ideal phlebectomy is to pull out the whole vein, because if you left the vein inside of the under the skin, you will get fibrosis, and you will get like slower recovering. And if you do that in perfect way, you will have no bleeding. You have to ligate the all side branches. You will have no bleeding. You will have no recovering. Your patients will be very happy with that only, not because of the recovering, but because of the aesthetic results. The all other techniques that you can use in surfaces, like giving the foam, is not the things that I love to do, because the sclerotherapy is giving a lot of hyperpigmentations, and it leaves bad marks on the skin, and that's why it's not belonging to the concept of perfection and concept of aesthetic. So here you can see the way how we do the phlebectomies. These are the side branches, and the side branches should be ligated, because if you not ligate it, it's going to be hematomas and bleeding. And see here how we make a ligation of the. Sorry again about the film. Using also the Varady hooks. And here you can see how we can completely remove the vein outside from below the skin. Of course, this is not it's not possible always achieve the good result, because the veins are sometimes not post-thrombotically changed, and the veins are something not easy to prepare and to pull it out. But sometimes it's going very smoothly, and sometimes I'm very satisfied with that. But also I'm giving to the point to the phlebectomy as the best way for aesthetic treatment. Okay, this is also one ligation of the side branches. So I would like to show you how you can ligate the perforating vein. So as much as I'm enjoying in using the endoveinous laser, I'm enjoying also in phlebectomies to doing it. And I think it's a really necessary thing in phlebology. This is the cocket vein pulled out, a little bit stretch to the fascia level. Delivered from the tissue. Okay, thank you for your attention. I would love to use this opportunity to invite you to the second VIP CLACS meeting, which is going to be in our training center in Belgrade, which is going to be like 5th and 6th of February. So you're all welcome.
Thank you, Peter, for your excellent presentation and this fantastic ultrasound videos. And there's a question from the audience. What about heparin therapy after the treatment? You give low dose heparin?
Yeah, we are not using the heparin since 5 or 6 years. Only in necessary cases, like we have thrombophilia or something like some problems with the coagulation, only in that occasion, but usually like every day, no.
One question from Dr. Klima from Austria was, when you go under the perforators with the laser, did you ever had a thrombosis?
Of the deep vein?
Deep vein.
Yeah. Until now, I had some problems with tibial, posterior tibial. Once I had a posterior tibial thrombosis, but it's resolved very quickly.
With this incisions in the mini phlebectomy, you give a suture or you give a Steri-strip? I mean, they were quite...
Nothing.
Nothing.
Nothing. Just leave it like that. So it's really important to make it clean, like to ligate the side branches. When you saw this circle that I have, I put it before with ultrasound and I put it on the places where are the branches. So I already know before when I'm going to make the incision.
Thank you. Is there a question from the panelists?
It's no question. Only I want to say this was a very good presentation, very, very good. And the leg was very bad. What for the better? To have to use the spatula more. Your finger is okay, but the spatula is better.
So, Professor Varady, I'm very happy because I got this compliment from you. So when I was starting with that, you were like a god for me, and all this, and every one of you were sitting there. And right now, the phlebectomy is really, really important. And thank you for giving us such a great instrument. I'm using spatula more, but in this video, I didn't show you, okay? But I have my finger a little bit techniques also.
Okay. What Varady taught me is that you always have to use the finger to feel where the vein is, and he calls the finger the intelligent finger. So it's very important to use your finger.
Peter, may I ask you, how long do you make a compression bandage after these legs you have showed?
Yes, just for 1 day, just for 1 night.
That's enough.
That's enough because the first thing, as I told you, it's really important to have a clean technique. Some of the vascular surgeon things, when I was teaching somewhere, like I don't know where it was, and one of the surgeons asked me, so why do you have to do it like that? So just treat that. But it's better if you put it all out, ligate it, make it clean, so no bleeding, no nothing. It's just to send anesthesia. The bandages are really important. It's necessary. But I'm trying to do as the best as I can with the phlebectomy and put the bandages only for 1 day, because it's not easy for patients to wear it.
Yeah, and no compression stockings?
Yeah, stockings, yes. But
yes, okay, great.
The bandages only for 1
Yes,
day.
perfect. The same, I'll do it. Yes, thank you.
Thank you.
Okay, we are quite on time. Is there one more question or?
Yes. I was very interested actually, because I thought it was a lovely presentation. Thank you very much. But it's quite interesting to compare you and Aldis as well, because you're both doing the same, advocating the same crossectomy with laser, but one of you is using a double ring and one of you is using a single ring.
Yeah.
My personal preference, like yourself, is a single ring because I find it more precise. But I was wondering what your feeling is the difference when you split the energy between 2 rings.
Yeah, Mark, very, very good questions, and I know what you are pointing on. I think in my really great love is 1 ring fiber, because I can clearly see the line of the ablation. With 2 rings, the line is not so clear, because we have the first emission and we have another emission, and the first one a little bit going foggy to the other one, if you understand me. And so that's why I prefer the one ring. I'm using quite a lot of power, a lot of energy, and always adapting the pullback speed, always watching what is happening down there and adapting to the vein wall, and that's how I make this precision or homogeneous delivering of energy.
Okay, Peter, we're good on time, and thank you very much for your fantastic presentation. And now let's move from Serbia to the heartland of Russia, to Chelyabinsk or Ekaterinburg, to the young rising star, to Denis Borsuk. Welcome, Denis. And his presentation is endolaser miniphlebectomy, literature and my practice. Welcome.
Dear colleagues, do you hear me?
Yes.
Do you see my screen?
Yes.
Fantastic. Do you see my t-shirt with Vienna?
Yeah, thank you very much.
Okay, so let me tell you about my practice and literature review of endovenous laser and microphlebectomy. I have nothing to disclosure. So nowadays we have several tactics of varicose vein treatment. It's treatment of saphenous vein and its tributaries, treatment of tributaries only, and also treatment of saphenous vein only and observation of the tributaries, as Uldis told us today already. So, and also Chiva method. I will discuss it a little bit later. So both of methods of for tributaries such as sclerotherapy or microphlebectomy have the advantages and also disadvantages. So for sure, after sclerotherapy, it's hyperpigmentations, which you can obviously see on this slide. And also microphlebectomy has also some disadvantages. It's rare, but it's possible to have them. Also mating as after sclerotherapy. It's not often, but it also can be in some cases. So, and as our teachers said to us, our older surgeons, that the best surgery is the one that hasn't been done. That is why nowadays we are using a lot of isolated endovenous laser ablation without concomitant tributaries treatment. So it's quite a good idea because we can ablate the whole GSV or SSV, and also all of the tributaries, competent tributaries, which create the volume of reflux, because we know that reflux volume increase caudally from saphenofemoral junction to distal leg with Venturi effect. So we can ablate the whole GSV, and after our study, so in one of our study, we showed that in 20% of cases, tributaries will completely disappear. And it will be reduced in 65% of cases. And we didn't have any changes in approximately 15% of cases. It means that in 80% of cases, tributaries will disappear or become less in 85% of cases. Yes, we can have some phlebitis, but in 75% of these phlebitis, which we had in 10% of cases, so, and 3/4 of them had significantly improved of severity score and had satisfying cosmetic result. It means that in these patients, so I say that it was like a essential sclerotherapy, you know. Yes, it could be some painful in a few days, but these patients had stockings. They started to treat this phlebitis immediately, and they had very good results and satisfied of the treatment. So as I told you, in more than 80% of cases, we have also not a reduction of tributaries, but also reductions of symptoms. And it's very important for elderly for patients. So for sure, you can see this patient, a lot of tributaries. I like microphlebectomy, but I don't like it so much to use it in this case. That is why I did just isolated ablation of great saphenous vein, and the tributaries disappeared in several months. So I think that most of you, if you knew that you have this situation, you would prefer isolated laser for sure. And also we know that it's difficult to use microphlebectomy close to the knee. And in this old lady, so we did also isolated endovenous laser, and just take a look in a couple of menses. So it's easier to do sclerotherapy for her, and he has improvement of her leg, you know, so from C4 to C2, I suppose. So the problem of the literature review of this tactic of isolated endovenous laser is the problem of all of these studies, that they included all of the patients in one group or in another group. But in our practice, we use isolated EVLT only in 80% of cases. That is why we have better results in all of these studies, because we do it selectively. But the problem nowadays is that we select patients for this tactic only with our experience, without any scientific evidence how to choose the correct tactics, simultaneously microphlebectomy or isolated isolated EVLT, you know, endovenous laser ablation. So just take a look of this picture, and what we had after 2 months is tributaries disappear. But so I don't know why we decided to do isolated laser in this case, because in my experience, I suppose that I would prefer microphlebectomy in this case, but we had fantastic result, and it's easier to do sclerotherapy right now. So what I want to conclude with isolated elimination of saphenous reflux, that this tactic has the advantages actually in summer period and among the elderly with symptoms of chronic venous disorders, and also in C4 to C6 patients for sure. But this tactic is possible only for patients who can be examined in follow-up period. So, and the biggest problem of this tactic is that we don't know yet how to choose the patients who will have benefits from this tactic, because we have a lot of parameters of reflux and veins, but we don't know how to understand how to choose, how to understand who will benefit from this tactic. Okay, and nowadays we are doing some examination, and it's funny that we use volumetry, quite an old method, but we didn't have any another options for measure volume of leg. And nowadays we try to understand our new parameters, such as index of power of reflux, and also we use peak velocity. So we try to understand how to choose the patient for this tactic, but we still don't know how to do it better. Maybe in the future we will have some answers. So endovenous laser has also the energy settings, and our previous study showed that with the same linear endovenous energy density, but with different power. So you can see here pullback traction speed. So we had the same linear lead, but different power, and we had different damage of the venous wall from 25 to 55%. It was big, significant difference. So you can find this material in PubMed. We published the paper in Russian, but you can find an abstract in English easily. And then we did a clinical investigation of these groups of patients, and we found that post-operative pain was similar in all of the groups. It was approximately 1, from 0 to 1, and occlusion rate was high, approximately 100%. It means that methods, thermal tumescent method, reached their peak. So it's difficult to do something better, because post-operative pain is too small, occlusion rate is too high. So here is our conclusion of the energy settings. You can use the same settings and have fantastic results. So that is why we have today a 1-ring radial fiber, 2-ring radial fibers. Then we will have 5-ring radial fibers. We also have different wavelengths. We have different steam, microwave, radio frequency, but occlusion rate, it's approximately 100%. Pain syndrome is very, very small. Non-thermal, non-tumescent method, I think that they are good, but not majority of doctors still prefer thermal tumescent method because it can give us fantastic results. Mark Whiteley do echotherapy treatment, but as Mark told me that for sure in the nearest future it will not be so popular as a thermal tumescent method. So that is why, in our opinion, we need to go forward and create something for a cost-efficient efficacy. And nowadays we use special device, so we can use, which gives us opportunity to do a reduction of prices of the fiber, because fiber becomes 2 times shorter, and this connection is also cheaper than this connection to laser. So by these 2 things of the length of the fiber and this connector, we have reduction of the price of the fiber 2 times, 50% of reduction of fiber price. And it's very good for us, for our patient also. Yes, we have a decreasing for 1 watt at the top of the fiber. It's not too much, and you can just put more energy on laser and use it. We can treat veins, very big veins with laser. It's not a problem. More than 4 centimeters, 2 centimeters, since it's okay, and more than 2 centimeters, it's not a problem to treat these veins. You can find our abstract in European Journal of Vascular and Endovascular Surgery. So about it, we have a huge experience, more than 300 cases, not a problem. Today we had discussion about extrafacial part of GSV. We treated hundreds of these patients, and we have a paper, it's in Russian. So we showed that we had just a 5% of complications, and all of these complications was just for a few months. In a couple of months, we had perfect cosmetic results. Just a 0.2% of patients had I don't know how to say it in English, like this situation, like this. We had it more often, but take a look at this lady. It is her leg in 3 months. So this complication disappeared. I beg your pardon, I don't know how to say it in English, but only in 2% of 0.2% of cases after 6 months they had some this complication, and you can do lipografting if you want, but that was an old lady. She didn't want to correct this skin. Okay, so if you have a allergy reaction to lidocaine, you can use just a cold tumescent saline solution. It's our paper, also in Russian, but you can find abstract in English in PubMed. So 40 cases without lidocaine, 100% success rate. So without sedation. It's very important that you can do it in ambulatory practice easily. Endovenous heat-induced thrombosis is one of the most popular complications. Nowadays, we can treat it with rivaroxaban. American Venous Forum published with Lowell Kabnik, so the guidelines of it. So honestly, we treat second class of EHIT with rivaroxaban also nowadays. We think that it's more safe maybe, but so okay, you can find our paper in internet, so our abstract, read it, so we have some material of it. And nowadays it's also not a problem with this drugs as a rivaroxaban. You don't need to use some heparins in incisions, or warfarin for sure. So damage of subcutaneous nerve can be also a problem for endovenous laser ablation. You can find our paper, also abstract in English, so in PubMed. So we found that some symptoms you can find quite often in 40% of cases, but it's just a small numbness. Patients feel it only when they touch their skin, when they wear their clothes. But in 4.6%, these symptoms reduced quality of life of patients, and we had reduction with the time. Just after 2 months, all of patients had a significant reduction. You can read it in, so you can read the abstract in PubMed of our study. So of course, puncture below the knee will give you more complication risk of nerve damage. But you know, it's not a problem in our opinion, because all of the patient was satisfied and this amount of complication of nerve damage, we suppose that it's because of it's due to inflammation after laser, you know, because it also nerve is going to this inflammation around the vein. So just shortly about Chiva. So you know, I will talk about recurrence rate just later, but for bypass, you know, with endovenous arterial operation nowadays, with growing of endovenous arterial operations, I think that it's not so important nowadays. We always can find something for bypass or do some arterial operation. But also I want to draw your attention of these two things: postoperative pain after laser. Yes, we can have it sometimes, but in our study we asked after 2 months patients with visual organelle scale, and the pain was from 0 to 1. Also, it's not significant pain. And spider veins, yes, sometimes we can have we can see the spider veins here, telangiectasia after endovenous laser. I cannot give you data, but I will give you in a couple of months, because we just finished our study with it. So we just made the pictures of the thigh before and after 2 months of endovenous laser, and in a couple of months I will give you. So now we will count it, and in a couple of months I can give you the data, how often it could be, how often, and what can we do with it, how sclerotherapy is effective for these reasons. And about recurrence, so you know, in the past recurrences was a big problem because patients need to go to operation. But nowadays we have fantastic methods. In one hand we have ultrasound probe, in the second hand we have a laser, in third hand we have a syringe with the foam. Nowadays 5–10% recurrence rate to ablative methods, it's so not the same problem as we had 10 or 20 years ago. So you know, we have these opportunities right now, and we are lucky with it. Microphlebectomy is, as I told you, in 20% of cases we do microphlebectomy. It's a very good, fantastic technique. We always use just Varady hook. Thank you, professor, for this instrument. It's fantastic. Here is our instruments for small veins, and this is instruments for bigger veins. I will explain you what's the difference. Here is the hook for mini phlebectomy. Here is just a simple mini phlebectomy, and we never use this hook because it's too big nowadays. In my clinic, we have like a museum, you know, on the wall, we have this like a museum. It says written that yesterday, today. And in yesterday, you can see this hook. For sure, it's too big nowadays. We never use it, okay? And about spatula, it's very important. Here is a B Brown 122 number of the hook, and it's spatula, and you cannot pull it through the 80 gauge needle. It's impossible. Your hole will be a little bit bigger. Not good. But look, take a look. It's a Hungarian hook from a very, very good hook for micro mini phlebectomy. It's smaller here, so, and you can use it with 18 gauge needle. Take a look. I'm doing microphlebectomy in this case, 18 gauge needle, spatula, you know, okay, and then a standard technique, and you can have very good results. Just take a look. You know, so I never do like this. I never. So, you know, take the whole vein, but for this meeting, I did it just to show you that you can, you know, that you can do this with microphlebectomy, but, you know, so it's easier to cut the vein and, you know, in everyday practice. And this is the result. Here is a little bit drop of blood. but here you can see that we will not have any scars in after procedures. Yes, we have another hooks like a ash hook, and these hooks I brought from Brazil, from Miyake Clinic. And also we have pin stripper, ash pin stripper. We never use these hooks because they don't have spatula, but we sometimes we use ash stripper, pin stripper also. For example, when you don't want to treat extrafascial part with ablation, so you can use pin stripper if you don't want to have some risky procedure, for example, for some young lady, or so it's possible to do. We do sometimes it, but not so often. And here is one of my last slide. So it's a nowadays situation. This patient came to me just yesterday. Take a look. She had sclerotherapy and she had big pigmentation after 8 months after sclerotherapy. And I palpated here a vein, and I understand that this pigmentation will disappear maybe in 3-5 years. I don't know, maybe never. And I did microphlebectomy. Here you can see the vein, and pigmentation becomes wider, but it becomes more superficial. And just after one course of mesotherapy with chelators, with some drugs from our aesthetics. So it's a result after one mesotherapy, but she will have 10 mesotherapy, and after Kuss-watched laser, and this hyperpigmentation will disappear. So as I I wanted to show you that in some cases we have really not a good complications, but with sclerotherapy, with microphlebectomy, nowadays we would have quite a good result. Okay, thank you, Professor, for this very good instrument. We always use it in our practice, and it's a very, very good decision. Thank you a lot. Thank you, colleagues, for your listening.
Thank you, Dennis, for this excellent presentation. Fantastic. Are there any questions from the panelists? Gonzalez is here. Sultan.
Also, I want to say also, this was very, very nice presentation, and the instrument, I corrected the instrument, and therefore the medical instrument is really better. Before the spatula is longer, you can prepare longer distance, and the hook also. And you presented an instrument. This was a very old instrument, and really we don't use this hook, only the other hook. And your presentation was very, very good. Thank you very much for that.
Are there any comments from C. Gonzalez or Philip Herzmann? Philip, how do you treat the truncal veins?
I use intravenous laser and micro foam, and I don't do phlebectomies, but I'm learning a lot during these sessions. And the only thing that concerns me that I've heard so far is these techniques where you're going so close to the deep system. And it sounds like people aren't having difficulties with that, but that's the one thing that I'm worried about. And I guess the comments so far are that people are not seeing increased episodes or problems with thrombosis in the deep system with these techniques.
Thank you, Philip.
Well, I have mostly the same opinion than Philip. We do also endolaser and microfoam for everything. We do not do phlebectomies. And we do also the old school endolaser, 1.5 to 2 centimeters away from the junction. So we keep the hemodynamics of the junction, including the epigastric, because we think that we have to treat the incompetent vein only. And if we have the branches of the junction not incompetent, and with good hemodynamics, we preserve them. So we leave a stamp as the old school endolaser. So we don't put so close the tip of the laser to the femoral vein. And as doing so, we do leave stamps, and we do also get rid of any endothermal heat thrombosis that we don't see using this technique that has been used for almost always. And then we do also microform for all the rest of the branches.
Thank you for your comment from Chile. One question to you, Gonzalez. When you have the big side branches, you will do the foam sclerotherapy in the same session, or regarding to the talk of Dennis another time, some weeks later?
We do in the same session, because if we have a GSV incoherent with big branches, we do the endolaser of the GSV, and in the same setting we do foam sclerotherapy. So in the order that we get to accomplish what the patient wants. They want to get rid of the varicose veins, so we do that. We get rid of them. Also correct the hemodynamics with the endolaser, and also that shortens the period of recovery. So the patients in 1 month will see that the legs are doing well and with no varicose veins.
Okay, thank you very much, Dennis. Thank you very much, all panelists. We go on, and the next speaker is Czernowitzki František, my friend and colleague. He just lives 50 kilometers from here in Bratislava. He's a general and vascular surgeon. But I invited him to come to Vienna, that he will sit on this chair next to me. But unfortunately, because of COVID, he was not allowed to travel. So please come with your presentation. And I asked him to present endolaser and mini phlebectomy, how to avoid complications. František, how do you avoid complications? You have to put on your microphone. František, you have to put on your microphone.
Yeah, now it seems to be that it's working.
Yes, welcome.
I hope that the presentation will be shared. Is it shared now?
Not yet.
Okay, actual now?
Not yet.
Still not. Now?
Not yet.
Inside Zoom,
now?
the screen function, the share screen function, the green function, share screen, press on it, select your presentation.
Yes.
Thank you.
Perfect.
Play.
And now I try to. Now is it okay?
Perfect. Welcome.
Thank you. So, my dear friends, dear Professor Varady, dear Alex, and dear all, thank you for the opportunity to be here. And I would like to talk about the complications. So the endovenous thermal ablations are recommended as first-line treatment. And this is because of proclaimed safety, effectiveness, because of fast recovery, and because of needless of general or spinal anesthesia. So majority of vascular or phlebological societies recommend this treatment as a first-line treatment. But of course, we are surgeons, and we know that every procedure have also its disadvantages and have some complications. The smallest are the redness, the hyperpigmentation, hematoma, hemorrhage, postoperative pain, and neural injury. So let me talk a bit about this. Sometimes I'm really surprised how different people are just documented a quite large number of complications. So if you are talking about redness or hyperpigmentation, it can be transient, long-lasting, or permanent. And for some patient, it's not a problem. For some patient, is it a bit a problem? They are just tolerated it. And some patients are infuriated. So you can have really a problem with these patients, especially skinny young ladies with GSV, which is really superficially localized. So for this type of patient, we never recommend endovenous thermal ablation if the vein is not deeper than 0.5 centimeters. And especially for these patients, I think the gold standard is the mini phlebectomy. You can be much more successful and the aesthetic result will be much more better. The postoperative pain. My personal opinion, as Dennis Borsuk said, that they have just really small pain postoperatively, that if the patient need to use any analgesic after operation, something was wrong. So I believe that if you are not using sedation or if you are not using general anesthesia, it's practically impossible that the patient have pain. It's just about ineffective tumescent anesthesia. It's about ignorance of critical anatomical zones when the nerve is crossing the vein or in the distal part above the ankle from the medial part of the calf. And of course, the ignorance of recommended energy dose. Very often we heard that the neural injury after short-saphenous vein is just a sensitive deprivation. As you can see on this picture, it's not true. If you ask the patient with neural injury to make a dorsiflexion, he is not able to do it. Yeah. Okay, and then you ask him to make it with the, but you see that he lost the stability on the leg. So this is not just a sensitive deprivation, and we need to be very careful, especially careful for the short-saphenous vein surgery in this patient. What's really interesting, if you are looking at the confession of this kind of complication, you can see that the surgeons which have high number of paresthesia have also high number of skin burn. So this is clearly an ineffective tumescent anesthesia problem. The second way and second important thing is to mention it that you need to do in critical zones the tumescent anesthesia from longitudinal view, and you need to really separate the vein intrafascially. So you really need to distract all the critical structures, the nerve, the arteries, from the vein away. So you start to apply your tumescent solution just when you are very close to the vein. So if you are moving in the compartment, there is no possibility that you will have a neural injury. The hematoma. Hematoma can be small and hematoma can be big, and it can be also an hemorrhage. So it happens also to us that we have puncturing the circular artery. So we then need to evacuate the hematoma, and it was not really a nice complication. But I think this is about the function of the vein or function of the artery, or sometimes about unknown hypocoagulability which the patient can have. But the solution is really to really control the needle, the tip of your needle, the tip of your device permanently during all the procedure. As well as I have seen also a patient with arteriovenous fistula, which was coming after short-saphenous vein surgery to our department. But this is not so rare as it seems to be on first sight. So if you are not controlling your procedure, if you have really not a good endovenous ultrasound skills, then I think it's a very dangerous procedure, especially in the region of the junctions. And as well as this 56 years old lady, which was sent to our department of vascular clinic 6 hours after radiofrequency. And as you can see in this phlebography, she have a nice superficial femoral vein, and here you can see the stop. So the common femoral vein was completely distracted with RFS. So I think it doesn't matter if you are using laser or if you are using radiofrequency, if you are not controlling your procedure, if you have not really satisfying anatomical skills and ultrasound skills, you can make a disaster. And other hand, you can see that what we have discussed in previous presentation, that there we have, especially in the beginning, a lot of patients with aneurysmatic dilatation of saphenous vein, especially when some doctors start this procedure 5 centimeters below the junction, because then still the stump was there. If the vein in the femoral vein, in the common femoral vein or iliac vein is insufficient, and there is still a reflux which is going through the preterminal valve and terminal valve, then after procedure you will have an aneurysmatic dilatation. So I think, and I agree, that there is a necessity to come so close as possible to the junction. Here is the phlebography, and here is the aneurysmatic dilatation. So I think on the beginning, we've seen a lot of discussion, a lot of presentation about the EHIT, how the EHIT is danger, and as well as one of the member of the panelists, Levo Kamnik, my friend, I'm really, it's a great honor that he is here, have published that it's much more safety to start a bit far away from the junction, 2.5 centimeters. There are a lot of works which recommend to start your ablation distally. But I think considering the EHIT, this is not so clear like it seems to be on first sight, because you need to read also between the lines. For example, if you compare the DVT and the EHIT, these are completely different processes. So the iatrogenic induced DVT on swines demonstrate much more prolific response, and there is much more recanalization after EHIT as after the DVT, and it is very important. So there are some accepted reasons for EHIT. The smaller length valve, the higher SEAP class, simultaneous phlebectomy, larger vein diameter as 7.5. But I think there is also one very important thing, and that's the surgeon skills and the surgeon's experience and the surgeon's technique. And it's very difficult to take it in account. So on the other side, you can see recommendation for better procedure if you are making laser crossectomy or endothermal crossectomy, how the Chris Rack have published it. So especially for the late accessory anterior vein refluxes. So we from the beginning try to do this old school technique. I mean the endovenous crossectomy concept. So come to the junction so close as possible, and the key for success is really to compress the vein, especially in the junction. So you are creating a balloon below the saphenal vein. You are pushing down the femoral vein, and then you really compress the vein. And if you have this picture on the ultrasound, what you see right now, then you can apply so much energy as you want, and nothing will happen, because I think if you really close the vein in the junction with enough energy, so the vein will be really shrinked, then you will have better results, and then you will have no EHIT. So these are our numbers till today, more than 4,000 procedures, and here are the number of EHIT. So paradoxically, we have complete EHIT in 4 patients with short saphenous vein treatment, but in these patients, we are not trying to come so close as possible, because for short saphenous vein, it's not possible, not important. Just these patients, all of these patients have a latent hypercoagulability. So I think it's not really, there is no reason to be afraid from closing the femoral vein if you are using an effective tumescent and if you are really precise and if you really control your procedure. So how to avoid the complication? First of all, start your procedure prepared. Evaluate the patient personally. Ultrasound, you need to make in vertical position and in supine position. Measure the larger denominator in the triangular position and define clearly the starting point for your procedure. I think it's important to make a draw map for the procedure. It's much more better than just to write a complicated text, because if you look at the paper and you see the map, you are oriented in 30 seconds. So take care about the patient comfort, about the thermal comfort. This is very important for the function. Take care about his fluid, the intake before the operation. Take care about his mental comfort. So it is the best way how to prevent vasovagal reaction it's much more better than to give some sedative pill to the patient. And it's important to talk with the patient from the first moment till you finish the procedure. And more or less, it's important to select the optimal device with your experience, with the anatomical condition, with comorbidities, with the age and the patient's preference. So actually we have the thermal tumescent, we have the non-thermal non-tumescent, we have the traditional surgery, as well as we have the foam treatment. And I think it's important for a surgeon who would like to proclaim that he's making phlebo surgery, that he need to be familiar with all of actually accessible procedures. It's important to start the procedure in anti-trembolable position. It's very important to make your punction very fast and without any pain, because then the patient is okay. On the beginning, you activate the navigation light before you start your insertion, so you can clearly control where are you going. And before you start your tumescent anesthesia, it's better to have the patient a bit in triangular position. So the vein is a bit smaller. You can apply much more easy the tumescent anesthesia, and as it is also a prevention of vasovagal reaction. You can apply the tumescent anesthesia from short access or long access. I personally prefer the long access, or in majority of cases, but sometimes also the short access. I think you can achieve a bit nicer picture, and you can see clearly the hydro preparation in the saphenous compartment. Our experience is that it's very important to have not just tumescent anesthesia, but you have somebody who is talking with the patient during the operation, because he is taking the attention of patient somewhere otherwhere. And this is the art of trapped one's interest. So the patient are just asking you, you are really ready? And in 20 minutes, everything is finished. So in my opinion, it is very important. So in a laser crossectomy, it is very important really to compress all the junction, to compress below the junction, compress it above the junction, and then you can clearly start your procedure. Of course, you need to control the lead. You need to control the pullback speed, as Peter say, and it's much more important to really control all your procedure with ultrasound. You can finish your procedure with mini phlebectomy or duplex guided foam. It's about agreement. For all the patients, this can be a quite nice procedure. The duplex guided foam, for them, the foam treatment or the hyperpigmentation is not a problem. For younger patients, I think it's better to use the mini phlebectomy, because have much more better aesthetic outcome. And for skinny patients, surely the mini phlebectomy is the recommended procedure for me. Immediately after procedure, you need to mobilize the patient. We ask him to be sure that he can move completely and there is no any doubts about his complete possibility to move. So that's the best prevention against AHIT, and that's the best prevention against thrombosis. So, and last but not least, I think you need to inform the patient about all possible complications and to create an atmosphere of confidence and to ask patient if have small problems, he will contact you because it's better to treat small problem as the bigger problem. And on the end of the procedure, we give the device to all our patients because in our country, there are still some surgeons or some phlebologists which try to use the single-use device twice, 3 times, 4 times. And there are some publication about the fracture of the laser tip or fracture of the laser device or radio frequency device. But this is a case from our country from 2017, where a 47 years old male was found on the street in tachycardia, hypotension, with very low hemoglobin and low saturation. He was sent to thoracic surgery to us. There you can see the X-ray, the left hemithorax is complexly closed. There you can see the CT scan. And after drainage, there was 2.5 liters of blood in the left hemithorax. And here you can see, because I was working before the vascular surgery on the thoracic surgery, what they have found on the medial pericardial side, something like that. And that was a broken RF, a part which was traveling 6 years in the body and then perforating the left chamber. So I think these are really single-use devices which are not possible to use 5 times or 10 times. So if you like to avoid the complication, I think you need to leave your comfort zone. It's important to know that there are some surgeons which are very skilled in arterial surgery, and I think that it's the same, that they will be also so good in the anovenous surgery, but this is not true. So if you like to success, you need to leave your comfort zone to develop your ultrasound skills, to develop your surgical skills, and more than that, you need to respect the rules. So these procedures are not procedures for general anesthesia or spinal anesthesia. And these devices are single-use devices. And I think from my point of view, it's important to handle all procedures because just then you can really decide for the best procedure for the patient. I think there are not better devices or worse devices or more safety devices, but there are better surgeons and worse surgeons, and everybody should treat this patient with respect, and everybody should try to do his best. Thank you for your attention.
Thank you, František. It was excellent. Thank you very much. And it's almost scary what we see, what you presented. And I know why you deserve that I will soon hand over the stick to you. It's the stick from Professor Varady, and it's always in the hand of the guy or girl who makes the Congress. And the next Congress will be in Bratislava, and soon I can handle over the stick to you. Are there any comments or questions? Larissa Chanuka from Ukraine, do you have any comment?
Do you have opportunity to hear me?
Yes, we hear you, Larissa.
František, I am congratulating you, and I immediately have felt native soul, because I have in my medical practice very often I have met such cases as you demonstrated, unfortunately. And that is why I have a question about your personal attitude to the stage approaches in the treatment of such patients with chronic venous disease. Maybe such stage approaches will help doctors, particularly young doctors, and will help patients to receive satisfactory results, and we will avoid of such complications. The first question. And the second question, what is your opinion about creation of specific recommendation? Specific recommendation considers the diameter vein, the pathology, because now we have a lot of knowledge in such field, and our group as expert, we are ready to create such recommendation, consider randomized trials and our clinical experience too.
So I think maybe it's not very popular, but I think this is still a surgical procedure, and therefore this is a question if the surgeons are able to transform the skills and if they will be able to do this procedure in good way. So I see much more complication after people which are not surgically educated. So I think if you have experience with the anatomy, if you see the things opened, I think if you see the junction, if you see the femoral vein, if you are not afraid to reconstruct the femoral vein because you are doing it on a daily basis, then this field is prepared for you. Of course, if you are not able to treat your complication, then you start your procedure 2 centimeters below the junction. But if you really have enough experience with the junction, if you open the femoral vein daily basis and this is not a problem for you, then you come much more easily to the junction, and you are not really afraid, because this is still a procedure which you can correct. But I think this is much more procedure for surgeon. And if you are not surgically educated, I think the majority of people which are not surgically educated are focused just on one procedure, on laser or just on MOCA or mechanochemical ablation. But if you really try to proclaim that this guy is ready, this guy is able to offer you the best way for your personal treatment, then you need to be familiar with laser, with radiofrequency, with mechanochemical ablation, with glue, despite I'm not using the glue because I have a problem with this, and the traditional surgery and the foam treatment. So just a person who is really able to handle all this procedure can, without any prejudice, use one procedure for the short saphenous vein, one procedure for the great saphenous vein, one procedure for the leg ulceration. We, for example, use much more mechanochemical ablation for the treatment of the leg ulcer. From double approach, we are going down with the device below the ulcer. So we are using also mechanochemical ablation very often. We are using laser, and we are using also radiofrequency. And in some cases, of course, we are making crossectomy if the junction is really big or large. So my answer is that the person who would like to do this must be surgically educated.
We are a little bit short on time.
Yeah.
One short question to you. Lesser vein. How deep do you go? How close to the popliteal vein to avoid complications?
Yeah, so we are looking for the tibial posterior vein connection. So if the deep vein is connected, we start the procedure about this deep vein connection to the short saphenous vein 1 centimeter above this vein. We never go closer to the junction because it's not important. And if this vein, the tibial posterior vein, is also insufficient, that there is a reflux and the vein is large, then we close also this vein.
When there's an aneurysma close to the popliteal vein, how close you go?
When there is an aneurysmatic dilatation, I prefer surgery.
Okay, Lowell? Lowell.
Yes, I had to unmute myself. So I go to where it starts to descend to treat, and I go no closer because of the tibial vein. And I'm using a forward firing laser, and with a side firing laser, as in BioLatex, perhaps you can go closer.
Yes. Okay, we are short on time. We go on. Thank you very much, František. It was excellent. And we go on now to Germany, to Frankfurt, to my old young friend, Zoltan. Zoltan Varady is a general surgeon, and he worked together with his uncle, Zoltan Varady, in the Frankfurter Special Clinic for venous disease. And nowadays he runs the clinic alone. Welcome, Zoltan, and have a good talk.
Thank you very much. I hope you can hear me. I'm not sure. Can you hear me?
Yeah, we can hear you.
Okay, you see the presentation?
Yes, perfect.
Okay, perfect. Thanks, Alex, for invitation, and thank to you told for the young colleague. Thank you very much, and greetings to Vienna. I hope you will do next Congress in Vienna also on a live and not just virtual. Thank you very much, and also to my uncle, to Professor Varady, on his work on the field of phlebology, and his 35th Congress. And I know how much work it is, because the Congress was about 30 years in Germany, and most of these Congress we did together because we worked together. So much work for that. We talk about his technique, and 35 or 45 years ago, he started with this idea for mini surgery and to preserve the saphenous vein. The only thing we had was the real crossectomy and stripping, and he saw the problems with this technique, with scars and edema and pain. So he developed his technique. For sure, nowadays times change a little bit, and we have the opportunity with the endovenous treatment, which is very good, and we do it since many years also. So it changed a little bit, and we have patients, we do the endovenous treatment, we do it with or without phlebectomy. Many times we do it in 2 sessions, we heard before, because it's better of the shrinking of the remaining veins in the lower part of the legs. But we have many cases, we just do phlebectomy for itself as a single treatment. So here I will talk about just the phlebectomy according to Varady and the technique and special indications. I have some slides there from Professor Varady, because we do the presentations together. So maybe you saw them before, but it's no problem. If you have cases like this, you have this lateral big side branch. The question is, what can we do? We can do for sure sclerotherapy. It goes faster, but we saw the pictures from the other colleagues. We have the problem of pigmentation. It is painful after that, and so it's a long-lasting healing. We do, in this case, is always the phlebectomy. So, but the question is, if you do phlebectomy, what is phlebectomy? Because you can do it more and less radical. These are some original pictures from Professor Varady, and for sure other colleagues try to do phlebectomy. But if you do phlebectomy here with 129 cuts like this, it's not an atraumatic concept and not a traumatic treatment, because you have the scars, the patient has pain after treatment, and the cosmetic result are very poor. Also here the stitches are very small, but plenty stitches. So it's not a good cosmetic result. And there are different kind of colleagues, they did this before. Dr. Hüller from Switzerland was a dermatologist, and different kind of hooks, Ramaley, Oesch, Müller hooks, but it's not the real Varady hook, because you need the special hook with the spatula. And the other colleague from Germany, very famous colleague, Professor Haag, he described in his famous book a case with a patient with a secondary lymphedema after mini phlebectomy with 300 cuts. If you need 300 cuts, that's not mini phlebectomy, it's a bad operation. So how we do our job? You need these hooks. You saw it before, and you know all of them. There are two companies, Esculap in Germany and Medicor. Nowadays we use more the Medicor hooks, but because they are smaller, and the spatula is smaller, and you can do it with smaller incisions, as we heard before. So how do we proceed, or how we do this? Yeah, in the beginning we do the marking in standing position, and we use these, it's called Edding, it's a German pencil. We use that for marking, and we do the black one because the black is long lasting. If you do blue and the green one with the alcohol, it will disappear. There are other medical skin markers, but they are not so good, and they are much more expensive because one pencil is about 1.50 euro. You see here, the marking we do is just small spot, because if you do lines and you make the incision in the line, maybe you have pigmentation like a tattoo. So that's our operation setting. It's you don't need many instruments. You see here the hooks, different hooks and the cramps, and just for disinfection and the lamp and so on. It's only a few instruments you need. And this also in a picture from Paswadi, we do it in local anesthesia. And it's very important to do it in local anesthesia because of the preparation of the vein. You see it here, and it's much easier for you to remove the veins in local anesthesia if you do it maybe in general anesthesia without this preparation of the vein. And we do it, Professor Wadi, in 0.25 solution. We do it in 0.2 scandicant solution with a little bit of natrium hydrogen carbonate because of burning. And if you do it in less concentration, you can give up to 250 milliliter solution. We just need maybe 50, 60 milliliters, so you're far away from toxic problems. And if I use it, I don't use adrenaline. Sometimes sometimes I do it in combination with the endovenous procedure. Then I use tumescence liquid with adrenaline. I like to do it without adrenaline much more than with adrenaline, because with adrenaline the skin and the tissue is a little bit harder. It's easier to remove if you don't use adrenaline. In my opinion, if you just do phlebectomy, you don't need adrenaline. Okay, here's other picture. You see this preparation because of the liquid, and in this case, I gave 50 milliliter solution for this leg. Okay, one more original picture. Then you do the puncturing. We talk about this puncturing, and in former times we used this Bayer thing, but now we do this this needle, this called no-core needles, because they're much smaller. And you see this picture, this different kind of needles. You see the problem, maybe you see it here. If you do small puncturing, you can do with this, even with this Bayer surgical blade, you can make a small puncturing. But if you do it too deep, you have maybe a hole about ½ centimeter or even more. If you know this medical this kind of blades, yeah. Even if you do a little bit deeper of a centimeter, it's only 1 millimeter or 1.5 millimeter. You can make a big hole. So nowadays we only use these small no-core needles. Very, very important. The most important thing is to use the spatula because of the preparation. Otherwise, you will not remove the bigger veins. And if you have fields at the knee or maybe at the ankle, then it's much more important to use the spatula. Otherwise, the vein will tear, and you just can't remove small pieces of the vein. You see it here. You see the instrument with the hook and the spatula part. And if you do the preparation, you see always the tip of the spatula through the skin, and you can feel it. And if you do it this way, it's sure you cannot have any problems because of nerve or damaging of deeper tissues. It's very important to use the spatula. And this is the other thing. We talked about the intelligent finger. That's the intelligent finger, because you have to press the skin, and you press the vein in the hook, and you can feel it, and then you can remove the vein. I heard a couple of years ago a colleague from Mexico, and he talked about the fishing technique to find the vein. That's really bad, because if you use a fishing technique and just go around, if you go fishing, there's much more chances to destroy or to damaging maybe nerves or skin nerves or lymphatic vessels and have problems. If you do it this way, it's go fast, and you're sure that you just have the vein in your hook. So that's a very important thing. You have to compress the skin with the vein. And then you grab it with the mosquito, and to do the preparation along the vein. And if you do this way, as once again, Professor Varady, you can divide the vein, and then you can have, or can remove big vein, or the big parts of the vein, long parts of the vein, through these small incisions, only 5 to 15 centimeter apart from the first one. So if you do an operation, you need maybe, it depends of the vein, but maybe between 5 and 15 or 20 max incisions. So it's not 300. If you need so much incisions, it's a wrong technique. And if you do it this way, you see this after operation. And nowadays we do always these stereo stripes. A couple of years ago we did suturing, but nowadays only stereo stripes. You have a better cosmetic result, and it goes faster. After that, we do this one dressing. A couple of years ago, we did always with bandaging. Nowadays, we change a little bit. Most of these cases, we use these stockings, because we have them in the clinic, and they're not so expensive, and it's easier for the patient to have the stockings as if you do bandaging. Here, we try to avoid to glue something on the skin, because sometimes if you fix it with plaster, then you have irritation of the skin. So we do nothing, only just little compress on the top, and then directly fix a little bit, and then we use the stockings. So I have some results and some clinical cases. This I showed before, this lateral side branch. If you do mini phlebectomy, you have a really good cosmetic results. Couple of weeks later, no scars, no pigmentation, very good result. But if you have other things, like here, the case, lady, she had a crossectomy and stripping before, but very, very big recurrent veins. So we do for sure phlebectomy, because in my opinion, if you use or you do sclerotherapy, you have pigmentation, painful, not a good cosmetic result. And if you have cases like this, then we do the operation not in one step, we do it in 2 steps. So here's the intraoperative picture. You see the big veins we removed. And as I told, we do it in 2 steps, because in the first step, we did just operation at the lower part of the leg, and we waited a little bit. 7 weeks later, you have these shrinking. Yeah, you see it. It's the same as we saw the picture with the endovenous vein ablation from Dr. Maurins from Riga. He do the laser operation, and we wait a little bit, and we see the shrinking because of the less pressure in the vein. And if you do it in 2 steps, it's much easier for you, because it's easier to remove these smaller veins as if you do the operation only in 1 step. And that's the pre-operation, the picture, and that's the result 12 weeks after the first operation. In this case, a really good cosmetic result. No scars, just a little bit of pigmentation. So the lady, I did operation 2 days only ago. It was November 19th. Also, she had an operation a couple of years or many years ago, crossectomy and stripping operation, but really big veins here at the ankle. It's a little bit difficult. If you start with mini phlebectomy, you shouldn't start here, because the tissue is very hard and it's hard to remove. But if you do the right technique, and you see it here, the picture, it goes up to the plantar part of the leg or the foot, up to here the varicose veins. It was intraoperative. It is a picture with this after application of the local anesthesia, about 30 milliliter of scandikain. And that's the picture in the operation. And you see here, you can remove a really big part, the long part of the vein with using this spatula. So using this spatula is mandatory. You even, in these cases, you have to. You see here the veins I removed. And after that, the steri-strips, and we did the compression after this picture, after the picture. And that was the picture yesterday, or the one day after operation. You see only a little bit, almost no hematoma, no swelling. You just need a little bit of blood or the steri-stripe. If you wait 1 more week, it's almost nothing to see. You can see. Other picture of the foot with an aneurysmatic dilated part of the vein, this ultrasound. And it's a little bit older, the picture, but also here you can see the vein I removed through these small incisions. It was 1 day after operation, that's 10 years ago. Now here we did sutures. Nowadays we don't do sutures, only steri-strips. And 1 week after operation, almost no hematoma, very good cosmetic result. Some special cases, it was a lady after breast augmentation, and she was complaining about the vein at the chest. It was disturbing her. And you see it here, the vein. At the photo, it's not so big, but it was bigger than you see it here. And if we did a phlebectomy as well, and you see here, we remove these small, tiny veins through these mini incisions. And 2 days after operation, little bit redness, but almost nothing. And that was 7 years after operation. You cannot see any scars. Some others, or the other special case, I have a few cases like this. This was a young guy. He did triathlon, and he was complaining about his vein here. And after long discussions, because I tried not to do the operation, we did it. And if you do it here, that's difficult also, because the skin at the face, the glabella, is very hard and very, very strong. And it's not so easy to remove, but as you see it here, we could remove a big part, or long part of the vein. And here 1 week after operation, only a little bit of hematoma. Just you see here these stitches, little bit of coagul on the point of the stitch, but it's almost nothing. And last case, it was a young lady. She was complaining about the veins at the forearms. I know with Alex, we had many discussions about that. How do we treat that? Do we do a laser? Should we do foam sclerotherapy or phlebectomy? Or do nothing? I think the best thing is to do nothing, but I have some cases. The lady, she was complaining, and after many long discussions, we did an operation as well in this case, but you can treat this case with phlebectomy as well, very good. And there was two different operations, one on the right side, one on the left side, but you see here one case intraoperative, that was 1 day after operation. It was, on the other hand, also intraoperative. You see, I removed long veins segments, and that was also 1 day after operation. This arm 1 week after operation, and the result, a couple of months later, with very good cosmetic results and no scars. Thank you very much for your attention.
Zoltan, thank you very much for your fantastic presentation, like always, and with a lot of humor and the pictures from Frankfurt. There was one question from the audience, if you have caused any lymphedema by taking out the veins from the feet.
No lymphedema. I have sometimes, but it's very rare, maybe once a year or less, I have a little bit of lymph cyst, yeah. but it's very, very rare. I have some cases, and then I do a puncturing of the lymph cyst and it will disappear. Maybe you have to do puncturing 2 or 3 times, but it's very rare. But real lymphedema I never had when I did phlebectomy.
Imre, any comment? Imre, you have to put on the microphone, please.
Okay, I hope you can hear me.
Yes.
Yes, that if there is a vein on the breast or on the chest, then inside that vein there is no pressure, so you can treat it very easily with sclerotherapy. It is not necessary to do anything. There is no coagula in the vein, so it is very simple. So this is my short remark to this topic.
Thank you. Sergio, what's your approach to mini phlebectomy?
Well, I wanted to take this chance to go back to what Imre said, because it's really interesting what they published recently with Colluri, who was showing the possibility of combining indeed the sclerotherapy to facilitate the phlebectomy results. So I'd like to have the opinion of Zoltan on this, if he read the paper and if he thinks it's a valuable approach.
What do you think? The combination of phlebectomy and sclerotherapy?
Yeah, Colluri published on European Journal of Vascular and Vascular Surgery the possibility of injecting, of course, first sclerotherapy to minimize the invasiveness of the phlebectomy, improving also the aesthetic results in this way. What is your opinion as expert?
I know that, but I don't have experience with that because we just do phlebectomy, and I do for sure the combination with sclerotherapy, but in most of the cases I do it after the phlebectomy for remaining small veins.
And it would be interesting also in knowing how extensive you go with the phlebectomy, starting from the Varady concept of, let's say, what became then the reservoir. Do you think it's important to ablate all we see, or are you limiting the act?
Okay, I think that's a difficult question because I know the concept of Professor Varady, and we did it together many years, but nowadays we do the endolaser and you see the advantages of the endolaser. So I have a big, real varicose vein trunk and with big veins at the lower part of the leg. So I do the endovenous treatment, I wait, and then I do the phlebectomy at the lower part of the leg because I think it's much easier for me and for the patients and I have a better outcome. But if the varicose, the venous trunk, even if it's refluxing, but it's not so big, then I do the concept of Professor Varady. I just remove the branches and then see what's happening. Maybe I have to do laser ablation a couple of years later, but at first I do just then in this case is phlebectomy. So I do both treatments or concepts.
So I take this chance to ask also to on the panel, because just a few weeks ago, actually, it was published a nice paper, always on European Journal of Vascular and Vascular Surgery, as a review showing how in reality concomitant rather than staged treatment is associated with a better quality of life and occlusion rate results. Do you think we are missing something in this data production? Because it seems that the big experts like you on the topic are all favoring staged, if I'm correct, rather than concomitant. Because it was pretty impressive to see this review showing that we should go concomitant, but it seems to me that all the experts today are agreeing in going staged.
Yes, I think so. I think it's a good idea, but even then you can have discussion about, because some of the colleagues there, I think it's difficult. It's different if you do it in Germany or the other lands, countries, because of our health insurance, you can do it in 2 steps. Because I do it the laser, and maybe little time later I do it again operation, because the insurance company covers the cost of the operation. If you do somewhere else and the patient have to pay for the operation, and it's difficult to explain to him to need 2 operations, then maybe you do it in 1 step.
Sure. And my last comment.
I think it's easier to do it if you have really big varicose veins in lower part coming from the reflux of the saphena. It's easier to do it in 2 steps, and you have a better cosmetic outcome.
And my last comment will be on the Varady approach again, that is then the saphenous sparing approach. When we are talking about staged, we always think about doing first the trunk and then eventually the tributaries. But what about doing the inverse? Because if you look at the Shiva or Asval or Varady, of course, concepts, we could stage first the tributary And
No,
the trunk.
absolutely, absolutely. I have many slides and speeches about, and we measured with the duplex ultrasound with patients with the refluxing varicose veins and the big side branches. And if you remove the side branches, you see a shrinking into refluxing grades of venous vein, and the reflux is less, and the diameter of the vein is better, and the edema maybe is better than before. That's a good concept. And it's hard to say which one you do. Yeah, it depends from patient to patient. I think both are good. Yeah, but you have to have the right patient for your treatment, as always.
Thank you and congratulations. Good job.
Welcome.
Okay.
Can I say something?
Yes.
Yes, I think it's still about the deal between you and your patient. So you can talk with all the opportunities with your patient, and sometimes you need to also adapt what the patient want to have. So sometimes the patient prefer endovenous treatment and mini phlebectomy, and some patients just would like to wait what will happen, and they are okay with it that after 6 months or 6 weeks they will come and you will control the state.
Yeah, absolutely, you're right.
Sure. Because some of the patients would like to have just everything in one session, but some patients understand your philosophy and understand your approach and are very satisfied and waiting 6 weeks or 8 weeks what's happened. Yeah.
Yeah, as always, you have to talk to your patients and you have to discuss the method and find a solution together with the patient, and they are satisfied. If you do something completely different, it's not good. You have just problems with the patient. So,
can I say something?
Thank you.
Yeah. Wait.
Also, I make the mini surgery about 40 years ago. At the time, we don't have laser. And this was the mini surgery, the best method. And then now, okay, we have laser. We can make combination. For example, the Uldis make also combination with other colleagues also. Also, the combination is the best. Sometimes this, sometimes the other method or the combination. Thank you.
Okay, Sultan, thank you. We are short on time.
Wait, may I make a comment?
Yes, sure.
By the way, I want to make a comment about the mapping of the veins. I use that.
Go in the next video. Really.
Okay, good.
Yeah.
So I'm waiting.
Alex, just one comment more, just the last one. My opinion about the stages is like that you have to, if you can, you have to do that in one stage, because it's better for the patient. Let's be honest. So why should patients should come to you for self? I know that there is insurance things here, you know, that you have to cover it. But if we are speaking about the patient and also about you, the best way to treat it is in one session, if you can treat it everything. So I think, but my experience also give me improvement about that.
Sorry, Peter, sorry. But I disagree with you, because we have a lot of indications where we can start with only with treatment of trunk veins with this axial reflux, and it improves a lot, especially for patients what you shown us today. Yeah, because for those patients with huge veins, like Dennis shown, with veins of 2 centimeters and more, with a lot of branches, you can reduce the stadium and reduce the veins. You can do this treatment less traumatic. And also for aesthetic patients, it's also the same, actually. Yeah.
Yes, but you're waiting. So sometimes post-thrombotic complication could happen in that reservoir, vein reservoir.
No. Complications can happen every day when we are walking, yeah. But you should always, I mean, if we can, how to say, most important is what I have learned many years from Professor Varady, that we should think about how we can treat patient with less possible traumatization. It is very important. Because of course, those veins what you're shown today, but we've seen in your presentation, those vein patient is with those veins at least 20 to 30 years need to harvest such kind of veins. Yeah, and of course, after that, patients can wait also some months after first stage, and then we can look further. Yeah?
I agree with all this because one of my teacher, Professor Ginic, say every time that it's important to make the smallest possible steps to achieve a satisfied patient.
Okay.
Same for the revascularization, just to make the smallest steps to achieve a satisfied patient.
Completely
Okay,
agree.
friends.
Thank
Okay.
you.
I have to go on, and next is my presentation. And you see the presentation? You see the presentation?
Yes. Yes.
So this is the view from my office where I'm sitting now, and you're looking down on the private clinic Döbling in Vienna, and it's a private clinic with 300 beds. We have 7 operation theater. Soon we will have more, and I have my office in this clinic. And first of all, not talking about the technique, but what I want to emphasize, we really need a good, high quality ultrasound examination. And I think it's not so important which technique we use, but I think it's important nowadays that everybody who operates veins should also make the ultrasound examination on his own. With the high definition ultrasound, we can see vein valves very clearly from the deep vein. You can see the reflux. This is a lesser vein, which is competent. And here you have the same patient with a lesser vein on the right leg, which is not competent, incompetent. And here you have a vein in the thigh. And after endolaser treatment, after 3 months, it's gone, it's away. But you have to make the ultrasound examination. When we look, also this I want to show you, that's what Dr. Damisch wanted to show us, the vein light for C2 varicosity. It's a very good instrument for having a better view on the veins. Now, when we look at the NICE guidelines in Great Britain, there's a clear statement: use duplex ultrasound to confirm the diagnosis of varicose veins. And then about the method you use. For people with confirmed varicose veins and truncal reflux, offer endothermal ablation, radiofrequency, or endovenous laser. If this not suits the patient, then you can use the ultrasound guided foam sclerotherapy. And if this technique doesn't suit, you can use the conventional surgery. Now I want to show you, it's like an educational video. I want to show you the procedure from A to B in our clinic. This is the view in our clinic. And this is the entrance for the operation theater for ambulatory patients. Here you see the patient with C3 symptomatic varicosity. We are marking standing and we are looking before the surgery. And here you see the diameter of the vein. It's 2 centimeters. I have the luxury situation that I always have as a manager, anesthesiologist. Sometimes people are awake, sometimes they want sedation. And here you see the introduction set of the laser. And now what's very important in this case, this patient has here an incompetent dot perforator vein. So we also, as a proximal point of insufficiency, so it's not the grosse, it's here in the middle of the thigh, this perforator vein, which we also treated. Now, the introduction of the laser, for this we use the big fiber. Many times we use the slim fiber, where we can go into the vein through a vein catheter. In this situation, we had the big fiber, and you see the double ring or one ring radial fiber, which is very important. We also do laser crossectomy. Now you see the introduction of the fiber, and we put the position in the groin, and we do the inner crossectomy. Now it's the position to the groin, and it's very good with this light. You always see the tip of the fiber, and now we look at the Dutch perforator vein, and we do the Thomas Sands anesthesia. We do it longitudinal and circular. And what we use nowadays, yeah, here you see the adjunctive foam sclerotherapy of the Dutch perforator vein. We do the perforators also with the laser. But in this case, we wanted to show you, we put foam at oxysclerol, and you can see here how the foam goes into the Dutch perforator vein. After the injection of the foam, we put Thomas Sands anesthesia in this area for compressing the vein, which we made the sclerotherapy. Now what we use since about 1 year is this pull-back device. And the advantage of the pull-back device that we can make some kind of accelerated treatments, because the fiber is pulled back by the device, but at the same time we make the Thomas Sands anesthesia. We don't have to wait for this. So it's much faster nowadays. When we do one day some surgeries, I have 2 hours more than as 1 year ago because of this pull-back device. Now I go out with the laser fiber. Here you see the Thomas Sands anesthesia. And always the ultrasound is with us. And now we start the second part. We do the mini phlebectomy. The Thomas Sands anesthesia I did before while pulling back the laser catheter. What you also see, please notice this, that the leg is elevated. So we have less bleeding after the procedure. Now, in this case, I use the 11 scalpel, but normally I just use a needle, but the guy had bigger veins. And now you make the preparation with the spatula, then you take out the vein. And when you look, there's no blood, or almost no blood in the procedure. The procedure are real bloodless because of elevation of the leg, because of Thomas Sands anesthesia. And you can always, when there's blood coming out, put more of the Thomas Sands anesthesia. Anyway, we already have the vein. I always also use the finger to feel where the vein is leading to. Sometimes you just take it out like this. Sometimes we cut it, especially when it goes over to the lesser saphenous vein, and I perform a ligation. I leave the clamp on. I cut it now myself. I don't need any assistance for this procedure. I cut it. I take off the clamp and I pull it back into the leg, the vein. I do stereo strips when it's really big, when it's big incisions. Sometimes I also did, like I think Janowicki said, that I don't, or I think it was Dragic, I don't put on any stereo strip, but in this case I put on. And now the patient was on light sedation. We wake him up, and he had also some things on the lesser saphenous vein, but he turns himself on his own. And again, my presentation is in a clinical setting. So I have the luxury situation that I have an anesthesiologist, which doesn't mean that he always makes a deep sedation, but he's like my operation manager. He gives comfort to the patient, and he does to the patient what the patient wants, what he deserves. So after the treatment, we have the stockings, which we have seen in other presentations. And the patient walks out. Here you have compression for not having thrombosis. I learned this with Jose Almeida in Miami. The patient is leaving on his own the operation room and comes to the post-operative care room, and there he stays about 1.5 hours. Also, what you can see here, I learned it with Nick Morrison, that we put on some ice, the leg is elevated, and after 1 hour, the patient leaves the clinic. Here you see the ice. And the patient normally comes back on the next day, and after 3 days, we make an ultrasound checkup. And now you see the checkup after 3 days. In the room I'm sitting now, this is the side. We take a look to the dot perforator vein, and the vein here, the saphenous vein, is occluded, and the dot, even after just one injection of the foam, was also occluded. Sometimes after 3 days, sometimes after 7 days, we take off the steri-strips. And this is the result after 4 days. And quite a good result. This patient, we just did the endolaser treatment, no phlebectomy. But in this case, the patient, it was summertime. He had to wait that varicose veins disappeared. And my opinion about this is that many patients I treated just with the endolaser told me that the veins disappeared for 80%, for 90%. But it was not the same perfect result when I combine ambulatory phlebectomy with the endolaser treatment. All in all, what I think, this was a 40-year-old man who came after 1 year in my office, and he was so happy about the improvement of quality of life. So we should always make it patient-oriented treatment, but it should always be minimal invasive, and it should always be with the use of ultrasound. Thank you very much for your attention. Okay, I hope you heard me.
Yeah, Alex.
Yeah.
Great film, great video.
Yeah.
You are using also spatula or not?
No, it's maybe a problem of the film that I wanted the guy who made the film to show the spatula. I think it was seen, but it's I'm sure I used the spatula even more than the hook. Sure, I live from the spatula.
Alex, that was a great presentation. I enjoyed it very much.
Thank you, Gonzalez. It was creative, no? Because still we have many people around, especially in Austria, who still do the conventional surgery.
One question: do you use
the one question left on my side?
Yes.
Can you hear me, Alex?
Yes.
I would like to ask a question. If you are next to the perforator with the laser fiber, why don't you use the fiber, and why do you use foam in this moment?
Normally, thank you very much for the question. And as I explained in the video, in many cases I use the laser fiber, but I also can see it also works with the foam. And one time I had a thermic problem with a lady, and she for quite a long time had some some pain in the lower leg after using the laser fiber in the thigh. So I'm a little bit more not so offensive with the laser fiber than I used to do it before. But anyway, many times, I could show you a video now, I also use the laser fiber for big perforator veins.
Can I? Yeah, Alex, I agree with you because, you know, in majority of cases, these large perforator veins, if you have incompetent saphenofemoral junction and destroyed terminal or preterminal valve, in majority of cases, these perforators are just re-entry points. So primary insufficient and refluxing perforators with hemodynamical impact is less than 12%. So I think if you close the saphenofemoral junction, there is no really reason to primarily take care about the distal perforator. Because if you make an ultrasound scan of this perforator and if you try to compress the vein and if you measure the volume which is going out and in, you will see that these perforators are not hemodynamically relevant. So I agree with Alex that there is no reason, there is not really rational reason to treat all these perforators below the junction. If the perforator is primarily insufficient and you have bigger volume which is going out from the perforation as inside, then okay, you can treat it. But in majority of cases, surely more than 80% of cases, there is no reason to treat the perforator.
But in this case,
sorry, Alex. Yeah, I would like also to. I completely agree with Frank. Yeah, because we are trying also in my clinic not to combine sclerotherapy and laser ablation with mini phlebectomies. Why? Because you are putting in foam in deep vein actually also at start of operation, and then you are doing, how to say, at least operations for 30 minutes, and this foam stay in deep vein, and of course then you have higher potential risk of complication because patients is not directly moving after that. Actually, we are doing that if it's needed, if it's really big perforator with laser, by using of laser, or after some period of time, after some weeks, after 2-3 months, if it's needed by sclerotherapy, but not, we are trying to reduce combination of laser ablation and sclerotherapy, especially at start of operation.
Alex, can I just a short comment? So I agree that we can leave a lot of perforators, but only below the knee. I disagree that perforator above the knee could be a re-entry point. Because it's different hemodynamic behavior. But on the other hand, I also want to tell you that we never close these perforators with laser or foam. I mean perforators of mid-thigh. We just close GSV above this perforator, and it can give you the same good results in long-term follow-up.
Don't you think it could be a source of thrombosis if you leave it open?
So, you know, so we observe these patients after 2 months and half of a year. So, and we never see some complications or, you know, some pain in this. So we just close GSV above.
Can I just say that in my practice, we get a lot of patients through who've had treatment in cheap vein centers that just do the GSV and SSV, don't do perforators. I don't know how many people get a good result because they don't come and see us, but we get loads of patients who have had the GSV closed, the SSV closed, and yet they come and see us with recurrent varicose veins. And when we scan them, they've got 2 thigh perforators, or 1 thigh perforator, and 4 baloney perforators. So a lot of people who get recurrences between 2 and 5 years have got perforated vein recurrence. So I think what we need is we need to know which ones are hemodynamically significant and which ones aren't. And that's the question. And we know that some of the perforators need treatment. We've got randomized studies showing for baloney ones, for instance, we know that if you get better results from closing them if you've got leg ulcers than if you don't. So we know they're hemodynamically significant, some of them below the knee. And we also know above the knee we get recurrences. What we don't know is which ones are going to be significant and which ones aren't until they become so. That's the difficulty.
Yeah, but if you don't have a reflux in the femoral vein, in superficial femoral vein and popliteal vein, and the volume which is going out during the compression or during the standing maneuvers out from the perforator, so why to treat the perforating vein? There is no reason.
You're not thinking hemodynamically, because when the perforators have their main action is when the vein is constricting. So you're thinking of passive flow when it's relaxing, so you're squeezing and look for reflux. But that's not when perforators have their reflux. Perforators have their reflux when you constrict the muscle.
Yes,
so
when you constrict the muscles,
So if the patient's walking, that's when you're looking for the massive reflux. Now you can't do that with duplex. The patient's moving.
Yeah, therefore you have the parana maneuver, no?
Yeah, but that's not physiological. That's not proper movement. The difficulty we have is that no matter how clever we are measuring diameters and everything, clinically, when we see patients 3, 5, 6 years later, we find people with ulcers because of perforators. We find recurrences because of perforators. So we all sit there saying perforators don't matter, and then we have all these patients coming through who have disease only because of perforators. We close the perforators, the disease goes away.
Mark, I've got to politely disagree with you. And I think that, you are emphatic in what you say and what you preach, and I think that's all relatively good. But I think we have to take each individual case as we go forward. If you have deep venous obstruction, all bets are off. You say that you get recurrences because of perforators there, but I would submit to you that we don't know enough about the treatment and what causes ulcers. We do know that it causes venous hypertension. So I think we can't be emphatic, but we have to understand what's going on. And then if we look at the systolic phase and diastolic phase underneath the curve of a perforator, when we're looking at spectral analysis, you can determine whether it's reentry or it's refluxing. So I think that you have to look at all of it. So, but you made a lot of good points, and thank you, but some of us may disagree.
I agree with what you say, and to a large extent, because I said there are many patients, I don't think all perforators need treatment necessarily, and what we need is better tests, because the difficulty we have at the moment is the ones we have aren't good. And the difficulty you have is once you can tell your spectral analysis and everything when it's still in circulation, then you do a procedure, take away the passive reflux, and then you need to redo your spectral analysis.
So one last comment. In the United States, unfortunately, there is no reimbursement for a non-pathological perforator. And a pathological perforator, as you know, has been defined as 3.5 millimeters, reflux greater than ½ a second. It's got to be in at least C5, C6, and now we're extending the C4B. And it has to be in the area of that ulcer. So these mid-thigh perforators or lateral thigh perforators, are not reimbursed. And I have a little disagreement with the insurance companies every time we get to that because of recurrence, as you said.
And you're quite right. I don't think we should be treating patients scientifically on reimbursement. I totally agree with you.
Okay, my friends. We move from Vienna to Mexico, and I say hello to Nora Sanchez, and she will talk about the endolacing combination of mini phlebectomy in Mexico. Bienvenido, Nora.
Hello, good afternoon. I would like to express my gratitude to Dr. Varady and Dr. Flor for inviting me to give this lecture. I am going to talk about endolaser in combination with mini phlebectomy in Mexico. My name is Nora Sanchez Nicolat. I am a vascular surgeon from Mexico City. The chronic venous disease affects a significant part of any population. Mexico is no exception. The prevalence in Mexico of chronic venous disease is 68%, according to the Vein Consul program. More frequent in females, 75%. In recent years, minimal invasive surgeries such as endovenous laser ablation have developed good results. I have been treating varicose vein with endovenous laser since 2003. At the beginning with the laser 980 nanometers, and in the last 8 years, I have been using laser 1470 nanometers. About the varicose veins, I performed the endovenous laser ablation simultaneously with mini phlebectomies and or echo-guided sclerotherapy. I used epidural anesthesia in all the patients with ambulatory stay. Our work starts with doing the ultrasound mapping. After that, we plan the surgical strategy for the veins which need to be treated. We perform the surgery, and if the patient requires phlebectomies, we perform it as usual. We follow up the patient by doing an ultrasound, and finally, if the patient has some residual veins, we treat it with echo-guided sclerotherapy. This is my work step by step. First of all, we access the vein in a forward position. After that, we change the position to Trendelenburg 1 to be able to empty the vein, and we infuse the tumescent solution, and finally we burn the vein. We use the tumescent solution around the veins in a neutral position to perform the mini phlebectomies. At the end, we put some local compression on the phlebectomies and put some elastic bandages. To treat the small saphenous vein, I use 8 microns linear fiber to treat the small saphenous vein. I like to put inside this needle, and I put inside the fiber, and I use the same position that the saphenous, gray saphenous vein treatment. My experience in 50 years is the following. We performed 182 procedures. Almost 80% were females and only 20% were males. The average age is 52 years. Nowadays I use the laser 1470 nanometers. The veins that I treated are the GSB, small saphenous vein, and accessory saphenous vein. According to the CAP classifications, the C2 stage was more frequent in 80% of the patients. The majority of them were bilateral, and the vein more frequently treated was the gray saphenous vein in 93% of the patients. In the 682 procedures, we performed mini phlebectomies in 83% of them. The gray saphenous vein diameter varies between 6 and 25 millimeters. The fiber used was the radial one, 800 microns, and the linear one for the small and accessory saphenous vein. The fiber was pulled slowly at the rate 1 to 2 centimeters per second, and for the 60 to 100 joules, using 8 to 9 watts of the saphenofemoral junction and tie, and below 5 to 6 watts. The mini phlebectomies were performed at the same time with the Varady's technique, using his hooks and spatula. Talking about complication, we had 3.2 of hits, 2 cases with iliofemoral thrombosis, one of them with unknown thrombophilia, 1 developed pulmonary embolism with good results. The total of complication was 9.9%. Continue with the results. The early occlusion rates following endovenous laser were 92 to 95 on follow-up at 10 years. The majority of recurrence occurred in the first 3 months. It was total or segmentary. And depending on the symptoms, we perform echo-guided sclerotherapy or second laser. Just 4 patients required second endovenous laser ablation. The longest follow-up was 10 years and demonstrated 92% of occlusion rate. The total or partial recanalization was presented in 80% of the patients, in 8% of the patients. At the moment, we have lost follow-up 18% of the patients. For the follow-up, we carry out the ultrasound after 3 days, 1 week, 3 months, 6 months, and then every year. We decided depending on the patient's necessity to continue with the complementary treatments, such as echo-guided sclerotherapy, transdermal sclerotherapy, transdermal laser, transdermal radiofrequency, and microsclerotherapy. Discussion. Majority of varicose veins arise from the incompetence of the saphenofemoral junction and great saphenous vein. Recent technologies allow us to treat this pathology with less morbidities. Endovenous ablation procedure has become popular with a high rate of patient satisfaction. We can offer the mini phlebectomy as well with no incisions and fast recovery. The different laser wavelengths are effective. We started with 980 nanometers and now we use the 1470 nanometers. And the only difference that we saw was the postoperative pain. Success after EVLA has been shown to depend on the amount of laser energy delivered, more than 70 joules per centimeter, not on the wavelengths or fiber type. We performed this technique with 682 patients. In our experience, the rate of occlusion was 92% at 10 years. The total of complication was 9.9%. EVLA combined with mini phlebectomy for treatment of varicose veins and saphenous vein reflux seems to be a very effective and well-tolerated procedure with minor complications. Thank you very much.
Okay, Nora, thank you very much for your presentation from Mexico. Which time do you have in Mexico?
11:10.
Okay, it's good morning. Yeah, here it's
Good morning.
I mean good night here. So are there any questions to Nora from the panelists?
The complications of 9.9%, which complications did you have?
Endoheat and some thrombosis, gastrocnemian, popliteal, ileothrombosis, lymphedema, ecchymosis, paresthesias, but just a small one was the most frequent, and the big one like thrombosis, because was a patient for a friend, and he didn't do the ultrasound control, and he didn't know about the patient had some thrombophilia too. That's the cases with thrombosis.
Thank you. And did you have a learning curve when you started till now?
Yes, of course, because I started almost by myself and with the laser 918, and now I think I have a better technique with the time, but my curve was really fast because I did a lot of patients at the beginning. Now I am treating less patients because there are more surgeons who are doing this technique.
Thank you and congratulations.
Thank you.
Okay.
One question.
Yeah, one question.
If I may I ask you a question that do you use bare fiber? Because I found that bare fiber is more painful than radial fiber. What is your opinion?
Yes, I use the radial fiber for the small saphenous vein, and for the other veins I use the linear fiber. Of course, at the beginning we start with the 18 nanometers with the linear fiber, because maybe because of the wavelength of the fiber, the patient had more pain. And talking about the perforating veins, because I am going to talk just a little bit about this, because I love the perforating veins. The only two things that we must treat the perforated veins is in the recurrence disease and when we have advanced stage of the chronic venous disease. There is any evidence to treat the perforated veins in the C2 stage? Thank you.
I think that the perforated veins was found in 50% in the parents' work, so in recurrent cases. So it is very, very high. So I think we need to think about the possibility that at the first session, we need to deal with the perforator way. So this is a subject of debate. Thank you.
Nora, I thought it was an excellent lecture, and thank you for being honest. What is your definition of closure that you had 92%? Because we're all different in what we look at, but I would like to know what your definition of closure is.
My closure is to don't have any segment more than 5 centimeters to recanalization. Any recanalization, the size of the vein must be smaller. That's all. That's my definition of closure the vein.
Does it include reflux at all?
Yes, I don't need to have any reflux, or just maybe a short segment less than 5 centimeters to make sure that the vein is closed. But that's my definition.
That's pretty standard. Thank you.
Okay, my friends, we are on time. Now the plan is following. We still have one lecture by Professor Varady about the history of the workshop. As it's a little bit late, first I want to give over this stick to František, because he's organizing the next Congress in real or virtual in Bratislava. And it's the history of this Congress that always the next organizer receives this Venengesundheit. How do you call it?
Staffel.
Yeah, Staffel, yeah, the Staffel.
Very nice.
Staffelholz.
The Staffelholz.
Yep.
In English, I don't know the stick. And also this candle here. And so I will handle over this virtual to František, and I think you really deserve it. The next thing I want to real say very much thanks to all the speakers. It was excellent presentations. I say thank you to the panelists, and I say thank you very much to our international audience. What I've heard, we had 580 registrations. So it's quite a big number. So let's go on now to the last. František, do you want to say something?
Sure, he has to.
Can I? Yes. So for the next time, I hope the condition will be changed, and I still believe that we will have a possibility to come to Bratislava, and we've been prepared for organization these big session in May of 15, but unfortunately this corona have destroyed our plans. But if the condition will be better, and I hope God helps us and it will be better, we would like to invite you all to center of Europe, to center of the Austrian-Hungarian monarchy, the crown town of the Austrian monarchy, and I think you will be surprised what wonderful things you will be able to find here, because this is maybe not so known like Vienna, but it's really a very nice and very wonderful place for living. We are 50 kilometers from Vienna, 200 kilometers from Budapest, 120 kilometers from Brno, 280 kilometers from Prague. So I think if the condition will be really good, the local people from Hungary, from Czech Republic, from Slovakia, and maybe, I hope, from Poland, and also from Austria can come here if we will don't have any corona barriers. And that will be the first hybrid Varady session. So we will make a local session, Czech, Hungarian, Austrian, Slovaks, Polish, and other people can be connected virtually. But maybe everything will be okay with this vaccination, and in 5-6 months, everything will be okay. So I hope and I pray for it, that the Father God helps us to overcome this problem, because nobody, just the God can helps us to overcome this problem, and we can see us personally, we can talk, we can make new friendships, we can make new contacts in Bratislava. So all of you are invited in Bratislava, if not personally, then virtually. And thank you for the opportunity to organize this meeting in 2022. I think Zoli is agree with me. We have decided to make it virtually, but also locally for the people which will be not in any quarantine, to come here and to see us personally face to face. So once again, thank you, Alexander, for organizing this meeting. Thank you, Zoli Baci, Igmondom, for the possibility to organize it. And we are waiting you in 2022. And the main topic will be my biggest complication in venous surgery.
Thank you, František, for your fantastic words. To all the panelists, all the audience, please take your time and watch the last presentation by Professor Varady about the history of the workshop. You can take your coffee, and it's with some humorful aspects. Before we leave for this session, Zoltan, magst du nicht jetzt noch die Abschlussworte sagen? Do you want to say now?
Dear colleagues, I am very pleased that despite the difficulties, all 35th workshop went off well. Some of the presentation could be seen live on the website, where our presentation can be seen and copied for about 2 months. All speakers will receive every year the presentation by USB pen drive. The next year, the 36th workshop, I think, we also take place virtually. The virtual is sure, and the andere is no. I better we make the plan sure virtually. And when the time better is, okay, we can change. I want to make the presentation. You all welcome. Please send me your virtual prepared presentation. That's very important, and therefore I said again, virtually prepared presentation. Thank you very much at all.
Okay, Zoltan, thank you very much. And I will go on to the last, I will say now goodbye to everybody, but I would be very happy if you join us for this last session, the history of the workshop. I will take a look if it's working now.
But was switching out. Of the 35th workshop, I established the Frankfurt International Workshop 1987. The history of the 35th workshop. Frankfurt. The name was established the Frankfurt International Workshop 1987 and ran it until 2015 in Frankfurt. The name was changed to Varady International Workshop for Phlebology, Lymphology and Angiology so other countries and cities can be integrated. The workshop had many participants, therefore I founded the Society International Forum for Mini-Surgery of Varicose Vein 1993 in Frankfurt. We had 1,500 members and more also. The workshop is the annual meeting this society. Every Friday morning for the first few years operated 4 patients, and between 30, 50 and 100 doctors looked the TV transmission at my clinic rooms. This part was very, very popular. The International Forum for Mini-Surgery Variation have President, Vice President, Board Member, President of Honor, Past President, and Past President, Vice President. This group change every 4-5 years. We have also advisory committee, very famous doctors all the world, and we have also honorary members, also very famous in all doctor all the world. In cooperation with scientific society, work, for example, the Accademia Mexicana Phlebologia y Lymphologia, Baltic Society and Phlebology, German Lymphology, Hungarian Venosus Forum, Society de Mexicana Lymphologia, for example, and Bulgarian Vascular and Endovascular Surgery and Angiology, German Society in Phlebology, Hungarian Dermatology Society in Polish Phlebological Society. We have also other societies. Here, 2 papers. We have also a congress with different other societies. You see here the Mexico Society and the Paraguay Society. We had also more papers with different societies. The first years, the workshop, we had every workshop 1 book. The book have the program and complete presentation. Later, we changed DVD. You see here the jubileum DVD from Frankfurt, and here, for example, Cancun, and here Budapest, the parliament you see here. The last year we changed again in Varna, the Bulgarian Congress. Here the sticks, the other sides, and here this year Vienna. We make up. We work together also with the German Society of Phlebology. We had together a workshop, and here very famous different doctors all the world, and presented my life work 2012, and here 1961 in Budapest I became my doctor degree, and 50 years later my gold doctor degree. Here we present the Mexico Congress. You see here the duplex teaching in Venenleiden teaching, and here the presentations rooms. The evening, we had a banquet, very nice banquet, directly the beach. Here the Hungarian group, here the South America and Mexican group. The very nice workshop in Riga, the Professor Maurins, the leader, and Professor Rabe, and me. I was present. Professor May was the Pope of Phlebology and mein Idee. Hier war often in Frankfurt, they looked my mini surgery and other method. Hier Professor Brunner von Zürich by Artist Design and Mini Surgery, present for Professor Brunner. And also present for Professor Brunner, the gold-plated Fleb extractor. And here present for Professor Bihari, an instrument, and the big things remain eternally, only we grow old. Very nice text. The countries of visitors of workshop found 47 countries. I think mein small workshop war ein World Congress, ist ein World Congress. The wisdom you can often ask yourself if a great effort is really useful for the medical necessity and the success. And other wisdom, to achieve good results, it is not necessary to use complicated and expensive instruments and methods, but to use your brain and the skill of your hands. The lecture, the University Rio de Janeiro, you see here the lecture and here the operating the University Clinic Mexico. You see the operation also under a University Hospital in Rio, and also in Rio meeting with Professor Mayal, Rio de Janeiro, Brazil, was very famous lymphologist. Here, the University Hospital Mexico, between two operations with the director, Professor Fink. And here, the meeting with the First Lady of Paraguay. I operated the First Lady and other also very famous ladies. Here we are again, Frankfurt, Professor Simonian from United States, famous professor, and here also Professor Sandler from Wien. Here the opera from varicose veins combined composite Sandler, Lindmeier, and Stemmer. We cannot present eventual other years. Here, other years, the workshop, Professor Krause, Professor Goldman, and Professor Bihari. And the other years, the Dr. Zinhagel, Dr. Stemmel, Professor Brunner, Professor Dimakakos, and Kollege Grote-Wohl, and me. Here, other years, Dr. Stemmer, Professor Völdi, very famous lymphologist, come from Hungarian, Glücken, Essen, Van de Molen, Holland, war auch very famous sclerotherapeut. Here, Professor Hache from Frankfurt, good friend, and Professor Rabe also. Here, Professor Cossio talked everything together. This book, he was the famous surgeon Vaskularchirurgen and the University in Madrid. And here Professor Santos Gaston written also 2 books. They come also from Spain. Here the other book, the Professor Vega, you see, he work also mein method. Here, very famous professor, the lymphology and phlebology and sclerotherapy, Professor Sanchez, Buenos Aires. I work also with him together. And here also, Argentina, Professor Vogt, we operated some years, different years, patient varicen. And no forgot, there's Dr. Sig, there's the book from Dr. Sig, there's before, after, very special method. You see here, standing position, and then let the blood out while lying, you see, and bilirubin injected and after wrapped. They had very interesting result. Here the famous Hungarian doctors, Professor Glowicki, worked the Mayo Clinic, Dr. Rado founded the phlebology in Hungary, Professor Darozzi founded the lymphology in Hungary. And we had also discussion journal, different countries and different famous doctor written. And the very nice workshop here, the colleague Flor, colleague Stefan, colleague Maurins, colleague Bihari, and me. The workshop with the first 30 Frankfurt and 1 in Cancun, and 31 Budapest, Bihari Karpati, Riga, Maurins Varady, Düsseldorf, Stefan Varady, Varna, Angelo Varady, and Vienna, Flor Varady. And this come, I hope, next year. Like the Olympic Flamme, the mini vein surgery workshop will shine on. And the workshop button you see here, the actual workshop president give the next president the button and the candle so that the mini surgery continues. Thank you very much.
Goodbye, everybody. Thank you for joining us. Ciao, Sergio, Nora, Peter, Rüdiger, Soltan, all this.
Adiós, doctor Varady. Muchas gracias.
Yeah, thank you. Muchas gracias.
Thanks, and stay healthy.
Stay healthy.
Hello,
Stay healthy. Goodbye.
Bye, everybody.
Thank you, Alex.